Good morning and welcome to this public board. We've got a full day ahead of us. We've got public board this morning. We've got corporate trustee, half an hour on the charity, and then we run into private board, and if we're all very well behaved, we're going to have time for lunch along the way, but let's see how it all goes. It feels, I always tell myself not to say this, but at the moment the agenda feels manageable. There's some proper issues in here, and there should be enough time for everybody to bring up any questions, thoughts, challenges they require. I hope I'm not having to keep my foot on the accelerator more than this is comfortable. By way of welcome, I've already promised not to reference this Laura's birthday, so I'm not going to say that. Some of you will have seen the telly last night, lovely piece on the planting of the sapling at Berwick. Well done, Marion, and well done, Damon, who's not here. I thought they both came over really well, and what a lovely event it seemed like it was. So, item one, particularly given that we've had the challenges with Berwick and with the delays, it's lovely to have a really nice positive feel about that. The other bit I just wanted to touch on was industrial action, just a chance to thank colleagues from across the organisation, including resident doctors, for the way in which people worked together during what was a challenging period. At our last session, we looked at the work we're doing to seek to improve the working lives of resident doctors and emphasise the importance of them being part of the team. And I feel like that kind of came over. I mean, there's more to go, of course there is, but I just feel that as a board we should send our thanks to staff across the piece for their efforts in ensuring that we not only kept the show on the road, but we really delivered during the building industrial action session. Finally, by way of intros, welcome to Joanna Mackay, who's observing from the comms team. New to the trust, I believe, Joanna. Welcome. So, can I check everybody any other businesses people want to give me notice of? No, that's good. Apologies for absence. Maria's phoned in sick. I think those of us that were with her online yesterday are not surprised by that. She was quite poorly, and she's still poorly. Any other apologies?
We have apologies from Dave and Steve.
Okay. Declarations of interest beyond the normal? Right. Good, thank you. Then we're into the formality bits first of all. Minutes of the meeting held on the 25th of September. We covered lots then. Winter, MMC, the Medicine Manufacturing Centre, GMC, violence reduction, research, and flu. And we were talking about hoping by now to be able to say that the board was fully vaccinated, and I think I'm right in being able to say that. I'm just looking around the room just to check. Anybody want to shake their heads? And thank you, colleagues within the Trust, for facilitating that or making it that much easier. Important message, leading from the front. We'll hear later about progress across the Trust, but as a board, we're 100% vaccinated the age flu, and I'm delighted by that. Thank you. Good. So, any issues from the minutes? Happy to receive? And don't you just love a green action block? Nothing I need to raise to any of you. Anything anybody wants to raise? In which case we're into Bijou, your update report, please.
Thank you, Laura. So I'll just give a very brief summary in terms of Chief Exec dashboard. So we can see here that we've got continued strong performance across all of our operational performance metrics. We continue to move in the right direction in terms of heading more towards the original constitutional standards. So continued strong improvement. I think it would be fair to say that is credit to the teams, because we are in an extremely, I'm going to say, difficult position as we head into winter, with volume of activity increasing as you would expect at this time of year. And then similarly, a strong performance on our money, our patient experience, our staff experience, and also within our safety and quality improvement priorities that we've identified for the year. A couple of things to pull out. I think Paul just mentioned there, Merrick Construction, so our construction partner for Berwick and the Medicines Manufacturing Centre. I think we've already seen on the news that unfortunately they are now insolvent, and we are working very closely with local contractors in terms of what our alternative arrangements will be to ensure that both of those facilities do end up being operational. Understandably, there is likely to be a little bit of a delay in the Berwick completion, probably Berwick more so than the MMC, but we are working through, and that's been reported through to Vic as well, about what our process will be next. And then I think, again, to echo your thoughts, Paul, around thanks to our teams for the recent strike support. I know this dashboard looks at October and the strikes were throughout November, but I think it would be only right to say a very public thank you to our teams who we know have stepped up during this period. And then a couple of things that have been announced in November, which in particular is around the Advanced Foundation Trust status. So the organisation was identified as one of 8 trusts to move into the Advanced Foundation Trust process. That's really moving at pace now, so remember, this is the thing that if we end up being declared Advanced Foundation Trust, that will give us some more freedoms as an organisation, particularly around how our money is spent, around capital and what we can do with any surplus that's generated. There are a number of, there are a number of things that will happen, particularly through January, where there will be on-site visits, I suspect, board to board, probably at the end of March, and we'll find out where we sit in that process, whether we've passed that process at the beginning of April, but a lot going on in the background to ensure that we can deliver on that. And then one other thing, just as a point which I think I couldn't not call out, so you'll see there our sickness absence rate. Although it's showing as red, it is heading in the right direction, so we're seeing a reduction. Obviously the team continue to work on that to draw that back in line with our ambition. To, again, good work that the team are doing, but we're not just quite where we want to be yet. And that's it.
Thank you, Bijou. Questions, comments, reflections to Bijou? All good, happy to receive. Thank you very much indeed. Let's go straight in, and we've got Patrick already in the room. Oh, here you are, Patrick. Freedom Speak Up strategy for us to, we're only being asked to note the content of the strategy, but will you be able to laugh, Patrick?
Yeah. Okay, so every trust across the country is required to have Freedom to Speak Up guardians, following the Francis report, which kind of looked into what happened when people didn't have clear mechanisms for people to raise issues in trusts and the consequences that have for patients and for staff working there. Joe and myself are the Freedom to Speak Up guardians for the trust. We've got a clear policy around this. We've got some really good programmes communicating out to staff about what Freedom to Speak Up is about. We've integrated that into a lot of our training programmes, and we've recently recruited around about 40 ambassadors to work across the trust, so they'll be able to publicise what we do. The strategy really is to pull together our intention and to be really clear about what the trust means by Freedom to Speak Up and how we welcome people's input into Freedom to Speak Up. We want to hear from people very clearly, because if we don't hear from people, we don't learn any of the lessons that we need to know about practice and about kind of behaviours in the trust. We presented this to People and Policy Committee yesterday. We got some really good feedback and some guidance about maybe making it a little bit punchier and being a little bit clearer about the fact that we do welcome staff speaking up to us and telling us what's going on, and also change a couple of the words. But it's just to, I suppose it's a framework within which we deliver our Freedom to Speak Up programme in the trust. So we welcome any feedback, and then we will publicise that on the website.
Thank you, Katie. It was discussed at People and Culture, and maybe just for purposes of any of the public viewing, almost every paper here, I think maybe every paper, will already have been scrutinised by a committee in some depth. So this isn't the first time it's reaching many people here. So, Katie, any key issues? We've heard that you wanted it to be punchier.
Yeah, that was just the key issue really. So it was reviewed yesterday in depth, as Patrick said, at BCC. And it was just to ensure it's punchy and to be clear who it was for, and to ensure it's got a little thumbria ran to it as well. So it wasn't approved at BCC yesterday. It will be come back to BCC once the changes are approved.
So that's why we're not being asked to approve it now. You're going to have a further bite and hopefully we'll be in a position to approve it in the new year. Bijou?
Yeah, thank you, Patrick. Appreciate this is not a strategy question per se, but you talk about the Freedom Speak Up ambassadors. When are we likely to have those? That's replacing the champions, or the term we used as champions. When we're likely to have those in place?
Sorry, so we had the induction yesterday, so that's the first time we had people in the room. I think we had a really good spread of people, I think right from senior managers and senior clinicians down to administrative staff. And our next meeting to kind of pull together a proper action plan is in January, so we're going to have some regular meetings with them to kind of agree a process about how they then go publicise Freedom to Speak Up.
So you've already recruited
We've
some.
recruited an appointment.
Right, okay.
And that's going according to plan?
Yes, yeah.
Okay.
It's exceeding plan, I think. We didn't expect quite so many people, so we put the sort of enthusiasm in the room.
That's okay.
It was just to clarify that point, I think there was about 40 people in the room that wanted to be the ambassadors, and Helen went and spoke from the HR perspective, so we're trying to make sure that there's a whole round of how Speak Up fits in with all the different processes, and I think that was really well explained, so it's a good event.
Good. Questions, comments, thoughts, challenge? Okay, so we're happy to note, we hear that there's further effort to get punchier. We hear that the ambassador route is proving popular, and we can be optimistic therefore about that working out well. And in the new year at some point we will be given the opportunity to finally approve the strategy. Thank you very much indeed, Patrick, well done. And grateful to you and to Joe for the work that you've done in maintaining this vital service. Thank you. Mike, we see you again. We saw you last time talking about resident doctors, and here we are, guardian of safe working. This feels as steady as she goes kind of report. Is that fair?
I think that's very fair. Sorry, it's a bit samey from the last one, but there hasn't been too much change.
Samey's good.
In Guardian of Safe Working. So I'll just run through, I shouldn't take much of your time. Hello everyone. Saw quite a few of you a couple of weeks ago, so it feels like this has come around really quickly. But nevertheless, you've got me again. So if we look straight into exception reporting, it's a bit of same old really, although there is a slight reduction in exception reports, and that was in Q1 this year. We had a little lag, which reasons for aren't clear. I don't know whether it was people finishing, getting towards the end of their year, or they were doing less, but we had a drop off in Q1, but that's picked up again, and we're hopefully heading to around the same number as last year. That may get affected by the ER reforms that are coming in February, which I'm going to talk about in a second. We might see a little uplift, but at the moment not much change to the number or pattern of our exception reports. The revision of the exception reporting system is a nationally agreed revision, and was due to come in September this year, but was postponed to 4th of February, which was a very welcome postponement because the backup with the electronic systems wasn't there with the original date. It's still not there, but we've had a chance to get some workarounds, and we're told that the Allocate system will be updated, ready for February. I suspect it won't be, and we'll be using the workarounds, but we've got the workarounds. The big change is getting exceptions signed off by human resource people, not your supervisors. There's a big emphasis now on confidentiality, that was felt to be in some areas stopping people doing exceptions, and that date is now the 4th of February. There's a lot of work going on in the people team to get this right. It feels lovely as the safe working team. We feel bigger now because we get to go to meetings with lots of extra people around this instead of just two of us. And it does feel good from that point of view. I do have some worries in general about this exclusion of clinical supervisors from the point of view of pastoral care, as well as spotting trainees in difficulty. But we'll see how that goes. There's still an oversight by myself to look for any trends, and I can then approach people who we feel there may be a problem. and I think that's despite confidentiality, it doesn't include me. One of the tough things has been putting together a list of who should be able to see them. I'm told Chief Executive may not be on the list, although I suggested that perhaps you should be. We'll see, and there's not really a good national steer, so we are sort of a bit in the dark with this one, because there's big fines if we breach that confidentiality. I don't think it's a big problem in this trust. I think this has come from other trusts, and when we go nationally and regionally, you see that in other places where there seems to be a much more, the culture in some organisations seems to be different than here around encouraging exceptional reporting. I'll leave it at that. So all on track. I think 4th of February is not now a worrying date. September was worrying, February isn't. Postgraduate Doctors Forum, in our last meeting in October, we had 23 residents. Bit of a dip from 32, but much better than when we had none. It's still a difficult group to reach. It was a quite positive forum. We usually get quite a lot of things brought up at forum, but getting the residents there is quite difficult. So we'll keep trying to encourage them. Comparing to regional, we've had some discussion at regional Guardian meetings, and I think we get as many as other places, particularly with the number of residents we've got. I think there's one place that is running at 0 or not doing the forum. So I think we're comparing is at least as good as everywhere else with numbers, and we'll continue all the work we do, and the drop-ins continue, and they're very useful for getting some information. I come to the mess twice a month to meet as many residents as I can here. It's a bit harder going out to base sites because there's nowhere that they want to really congregate. So that's ongoing. Rotas, nothing really to report. Our compliance is still 100% with compliance to the rota rules. There are gaps, there's some gaps you'll see in the report, there's a table with some of the gaps, and actually our numbers of gaps are quite low. It's sort of half a slot per rota, if that, which is a lot better than it has been in the past. We'll just keep working on that. A little bit of work ongoing about trying to revise the rotas, which sort of links into the 10-point plan. I wasn't going to talk a lot about the 10-point plan because we talked about that a couple of weeks ago. Quick update was we had a very positive meeting about rest spaces yesterday. We have located the rest rooms in the wellbeing centre, and apparently they will be alarmed sufficiently to be used. So there's some potential progress there. Shut up now.
Well done, Mike. Thank you. Johnny.
Thanks very much, Mike. That's good, and I'm pleased that Elsa, our head of lead, was able to go. I'm sure we'll be able to bottom something out that will meet the needs of most people. I think it's very difficult to please everyone's idea of what a rest space would be. Can I just ask you, because you've had a junior doctor meeting in October. Was there much excitement about the 10-point plan, or?
I think there was a lot of no knowledge about the 10-point plan,
really?
If that's what you mean. I think it's news to most of them. At drop-in, I sometimes ask them, have you heard of the 10-point plan?
Do we need to
But
do
they
something?
haven't heard of a lot of things, so.
Do we need to do something proactive in the comms around that?
I think having Elsa in post is going to help, definitely. It's going on to the resident forum agenda. We've made everyone aware that Elsa's in post, so there's been some comms out to them as far as we can about that, which should lead to the question. We've had some interest. We've asked for people to come forward who want to do some project work, and we've had 2 or 3 other residents come forward who are quite interested. So I think Elsa's going to try and develop a little bit of a representation tree down into some of the other groups, because she's a senior trainee in surgery, so we can go through the foundation doctors. They're the big groups to get hold of. but also the ones who probably have the least knowledge around it. But I think 10-point planning, the stuff they know about is what they want. So there's a survey going out around food, around rest, around all the points on particularly well-being on point 1. So I think they know about the issues rather than know that it's all grouped into the 10-point plan.
Okay, but I'm just thinking we have got quite a good story to tell. I mean, there's a time of industrial action. We don't have a locus in relation to their salary, but if we're taking several positive steps to try to improve their working lives, then we should be making that clear sometime.
I think so. I mean, I hope when we're all having to report back nationally about where we're up to with the 10-point plan, and I'm hoping there'll be some sort of league table produced, because I think as ever we'll be very positive on that. When we saw the 10-point plan originally, we weren't too worried. We had ongoing work in all those areas already.
I mean, the trickiness is that, whilst they will read, they do have access to email, but the way to communicate with them, I think, is best through their peers and through the forums such as mine. I really do, which makes it feel a little bit different. We can sing it, large from the roost, but we do have a good reputation, and we do get trainees residents who like to come and work with us because of our approach to things. So, and that's how it spreads. It spreads through the community.
It's social media rather than.
And we don't have that. We don't have access to their WhatsApp channel.
Well, we have a bit. We can sneak in a bit. So we are on the forums.
Thanks, Mike. It was just a comment from the exception reporting item. It's a shame. So it was a double-edged sword with a confidentiality element, isn't it? Because I think as an organisation we would pride ourselves in wanting to be one of learning and improvement culture. And I think I was up at ED this morning and having the same conversation with David around we want to know any of our resident doctors, any of our trainers that are in difficulty or perhaps need some feedback purely from a confidence point of view or how we can support, and from an exception reporting that just might be it's taking them longer to do things, how can we help you to get through that, and it's a shame that you're almost your hands are almost cut off to try and help people and it turning into a negative experience rather than a positive one of I was able to say I was in difficulty and somebody took me aside, said right, let's work out what's specific for you rather than the blanket approach that we tend to give some of our trainees. So that is a shame, and I'm not sure whether it will ever change or not. I get that it could be used differently in more organisations.
I think we'll see what happens in February. There's a national expectation there'll be a big jump in exceptions. I'm not sure we'll get them, which may give the temperature of we didn't have a problem. We'll see. They'll probably go up a bit. We have picked up doctors in difficulty through exception reporting systems, so it is a worry. We've got to get better at spotting it from a dashboard perspective and that sort of my oversight side of things. I think as well as that, not just the difficulty is instant changes. So if you're staying late, speak to your clinical supervisor, you tell them why, and they say, well, maybe you could do this, maybe if you took your break then, and they don't get that. So you would expect people to do more exceptions at the start of their career, and then less as they get better in time management, etc., etc. So I have got concerns about that. I think it's really difficult because it's a national issue rather than a local issue, and I think it's been steered by things that are not Northumbrian issues.
Jeremy?
Yeah, so I think you're exactly right, and I think we would entirely agree with you. And we can but reflect on the benefits of these top-down systems that apply equally to everybody. Because there are things within the 10-point plan that you could achieve them and actually wreck the way that we do roads and the way that we work. And I think this is the difficulty with doing large-scale HR at a national level. However, I do believe there are some very fundamental differences between the way that we work and the way that other organisations work. And just talking about the numbers of elite resident trainees and resident LED doctors who are not in training, and with their proportions on some of the calls recently, really does show that we're all trying to get people in proper posts and proper jobs, which other places aren't able to, which is a shame.
Okay, any more questions or comments to Mike? Helpful report, largely reassuring, assuring in terms of our own performance, but significant concerns about the potential implications of the new system when it comes in February. I'm conscious that on occasion when a national system comes in that's bonkers or that we judge as bonkers, we go fairly strong on it. This may not need to be one of those if we think that we're not going to be personally enormously negatively affected by it, but I don't rule out the thought that we might want to be assertive on this issue if things start going wrong, because the idea of cutting out the opportunity of the clinical supervisors seems to me to make no logical sense at all. But, okay. Mike, thank you very much indeed. See you again soon. And we're straight on, seems like every couple of weeks we see you, Mike. Can't wait.
Hopefully not between months.
Now we're into the Staff Flu vaccination campaign. Nicole, before you came in, we noted that the board is 100%, that we were proud to be able to say. We haven't quite got 100% across the piece yet, but thanks for your report.
We are trying. So, good morning everyone. Nicole Cosiodi, Head of Public Health and Wellbeing. So we are, since obviously the paper was submitted, our figures have gone up slightly. So the overall figure for frontline staff is currently sitting at 50%, which is 13% higher than what it was this time last year. And for our non-frontline, it's 42%, which is 8% higher than last year. We have, we started the vaccination season with roving the high-risk areas, and then we went into hubs, so we delivered hubs throughout October, and then we've gone back into roving again to obviously be closer to people and try and vaccinate, taking obviously people's feedback on board. We have put some hubs on for December as well, again, so people can book in. The bookings haven't been as high as we would have liked, but again, I think that's probably because people are waiting for us to go to them, which is what we're doing. So in terms of the breakdown of the business units, NPC are at 64%, corporate services are at 61%, child health at 58%, clinical support at 54%, emergency care and medicine at 48%, surgery at 45%, NHFM at 44%, and community business units at 36%. We are doing some further work in the community because we do appreciate figures are a little bit low there, and we suspect that some people may have been vaccinated by the GP practices, which is probably why the national data is coming out at 50% for us, whereas we're reporting 50% because we don't quite know everybody who's been vaccinated that haven't told us. If we look at organisations across nationally, we are sitting second for ones that have got a similar denominator to us, and in the region we are picked by 1% by Newcastle. So we'll continue to do the roving, and any suggestions would be more than welcome.
Nicole, thank you, and it would be churlish not to congratulate you and your team on the progress and the improvement since last year, even if it's still irritating that it still feels such a low number, doesn't it? But we need to be grown up about this. Kate.
Thank you, and yes, thanks to Nicole and the team. I think the feedback that we're getting across the trust is one of convenience. So people not booking in and going to appointment, but if the team are on the ward and they're there, or they're on a break, or they've got time, they will have their jab. So Nicole and the team are going to do a bit of work of when the best time is to go on the wards, because I think sometimes they turn up and it's a very, very busy time and staff can't then come and have their jabs. So there's a bit of work around that, and then we identified that the community needed a bit more targeting, so the roving teams are going to start to the community. And also nursing colleagues report lower than our doctor colleagues, so again just some intervention there, and I spoke to Chris and Elaine about that this morning, so keep going.
Jeremy.
Yeah, thanks very much, Nicole. I mean, it's better than last year, but I think I'm with the chair. It's not where I would like it to be. I do wonder whether part of the issue is an attitude in younger staff members of invincibility. It's sort of seen as a thing that on vogue is like you need the flu care. Because no, but there are that element to it, and I wonder if there are any snazzy things that we can do. I notice our resident doctors aren't quite role modelling the senior doctors, and I suspect that they will be able to be persuaded, but it's just not really front and centre in their thinking in the way that it perhaps is. I don't know whether it's probably not believed.
Am I right in saying that the variant this year is actually impacting on younger people more than previously? Did I hear that? Where's Alistair? Yeah.
Be honest with
I think the answer is that it's impacting on everybody, so more than previously. So there are more younger people affected, but I don't think they're disproportionately affected as opposed to an increased percentage compared with last year.
I just wondered if that was a comms angle, but yeah, okay. Katie, and congratulations on NPC at the top of the charts. Yeah.
Thank you. We have pushed them carefully. I'm hearing back from a number of colleagues and staff members that they're just getting fed up of being asked to have the flu jab, and it's thinking about for next year whether we reverse the psychology in some ways. People are being stubborn and being told I've got to do this, so I can stand back and rebel. So it's how we carefully maybe change the narrative around it next year and sort of think through more. That's okay.
There's only a few, there's only 10 available. Can we watch the queue?
Yeah.
Absolutely. Maybe worth.
We need one of those nudge experts. Okay. Other thoughts? Nicole's asking for further inspiration as to how we can get further. And I think probably the best we've got is thinking about the barriers and the psychology.
I think there is something, Kate and I have had this conversation just a little bit about some learning from how various business units have approached the staff survey, the National Staff Survey response. We've seen numbers like we've never seen before come now. There'll be something about maybe everything's trying to tell us something. But in terms of completion, there's got to be something, and HFM, we're off the starting blocks really quick on that. Some fantastic scores there. There must be some learning in that. Again, because it's the same group of people, I get it's something very different. And actually, what could we perhaps learn from how we approach that this time around? Because it has been different.
Yeah, although I haven't worked NHFM on the stuff that's on the flu vaccinations. But Veronica, any reflections?
Well, with the staff survey, I'm recommending the Football League table because that's what's worked in departments that start in a conference and want to get up to the Champions League. That's where you made a difference. So that's how it's done. It's set up like a Football League table, and people can see where they are, and they want to, get out of whatever league they're in and progress. So that's, I think, has made a great difference. And the team have just been really, really on it this year. So I'm really pleased for them because it's been a lot of hard work.
Yeah. Okay, Phil's turning up his nose about the Champions League. I'm saying nothing, me.
I just didn't realise we were allowed to talk about football.
Alistair.
I think we need to be careful. I think there are different factors with flu than there are from filling in a staff survey, which there isn't a negative health consequence to, and people are worried. So I think that I actually think Katie's right. I wonder if we clarify the people who opted out of flu, which won't be 50%, it might then allow us more to actively target those who haven't opted out. And I think one of the other bits is the reason NPC, and I think primary care is generally ahead, is they've got vaccinators there every day, and they just say, just grab at any time, and so they've got the constant presence of the availability of the vaccination. So I think there is some learning around both peer vaccination availability and possibly the opt-out, because I do think we're reinforcing negative bits where people just feel they're not, and that creates a bit. But I am wary that you can't apply some well, there isn't, you know, the staff survey is just a good thing to do, and it's a bit fun, and I can see that. I think there are pitfalls to try to compare demographics and all sorts of other bits too early in terms of league tables.
Which suggests Kate's point about convenience is possibly the most important. Ruth and then Ross.
Nothing wants to word to it. I'm just going to pick up on community, because it worries me sometimes that community often feel like they drift off the bottom of some of these tables, and because they're remote we know that, and whether or not the peer vaccinated thing works as well in community, because we know that often they'll have a morning huddle, they might all be in for their start of shift or their start of their night shift, and whether or not we're doing enough on that, because they're the ones for me, if I was in that situation, community where I would want to be vaccinated, given that I'm in and out of people's houses.
Absolutely, and I think peer vaccinators has been the change in our model this year. We've taken a lot of learning from how we rolled that out, so I am hoping that we do that better. There's something about starting earlier in the year as well, and now again we've started earlier this year, but we need to be even earlier the following year. It was interesting, had a conversation this morning about a lot of the community staff being based at CBX. We can't vaccinate in CBX because from an insurance point of view, so there are a few little barriers.
Yeah.
They won't allow us to vaccinate because it's not our building, so yeah, there is. So definitely we need more peer vaccinators, but yes, that is one of the, because we know a lot of community staff.
That really feels like we could do something about that, I have to say. I've got Ross and then Anna.
I'm just going to make a point, I think Nicole is right, and her and her team and my team have been working really closely on it all with Danielle and loads of others. And I think the feedback we get isn't necessarily around, oh, I don't know or I don't want to, it's the convenience. Oh, I would have if I could have, but I was too busy or I was somewhere else. And that's the thing that really hammer. I think there's a danger it can really overcomplicate and try lots of different things, and actually it's about convenience and having people there at the right time in the right place, and they're working really hard.
Do you need, are you responding to that point? So I'll keep on with Anna, and then I'll go Alistair and Jeremy.
We've had lots of conversation around this within the community board, and all the points have been discussed. I'm just mindful thinking about the sickness absence rates. They've had lots of long-term absence. I'm not sure how we include or exclude those individuals and how other organisations do that, and those that are on maternity as we're benchmarking around the region. That might just be something to worth thinking about. I think they are removed from the denominator in some of the organisations.
Fair point. Alistair and then Jeremy.
It's just we need to be slightly careful about going too early because the immunity wanes, and actually that's where classically we could hit the target but miss the point. If we get, this year it's helpful because we've got an early surge. If the surge was typical or whatever, then actually you go too early and actually people's immunities vanish. So the benefit actually for our staff protection is gone.
I was thinking that, Jeremy.
So I'm just thinking that it's probably both convenience and opportunity. It has to be an opportunity, and I do think if I look at the way our nursing staff work and the way our senior medical staff work, there's a lot less flexibility in the way that our nurses work. So even when you're on the wards and they're treating them, it isn't easy to give them the opportunity. So I do think that is something that we may need to think about, both with the community teams rushing off people traffic, whatever it is, out in the car, that does prevent them even when it's convenient. And there may be similar issues with junior doctors. They won't be there as much at the time. They may be there out of hours, so when they're there, it won't necessarily be convenient to be able to do it.
Okay, good. Marion.
Thank you. And thanks, Nicole, because I think the team are doing a really good job. I just wondered about maybe something like intentional rounding, particularly around NSEC and the acute sites. Just going around every hour with the team, going in and out the wards. I think that some other areas have tried that, and I just wondered if this is the time now to do it. Because if you miss it, as Jeremy says, not everybody can just drop everything and go. But if they know that somebody's coming round, the next time, then maybe they can sort of look at their work pattern to do that. And then the other thing is, I wasn't aware about CBX, I don't know if you were, I think that's probably a risk assessment that we just need to take out at this meeting. I think the risk of them not having an injection is more than actually, but we need to do it properly and all the rest of it, but I think that'd be well worth doing.
Good. any more. This has been a really good discussion, and just the reminder for, as if we needed it, this is not just a tick box exercise. The higher we get on this, the more we're keeping our patients safe, the more we're keeping our staff less likely to be going off sick as well. So this is a core piece of our clinical work, and I thank you, Nicole, for the work. We're congratulating on work done so far, but we're far from satisfied that we've got as far as we want to. I think we focused in on, I think Jeremy's been helpful, that we started with convenience and we moved from convenience and opportunity, and that sounds like an important thing. And we don't want to lose the recognition of how to work around those people who are stuck, those people who are wishing to opt out. We also need to recognise there will always be some of them. Where there are practical things like CBX, let's take it off the line, but let's see if we can sort that. Probably by next year rather than this year, just the way these things often work. But that's been really good. There's always more comms, and don't forget the fact that the board is now 100% vaccinated. So if that's got of any use, then let's make sure that we use it. Good, thank you very much indeed.
Thank you, all points taken. Cheers.
Good. Okay, ready to move on? Patient and staff stories. Well, I remember last time we said we need to make sure that we kind of mix between good, positive, uplifting stories and those that would give us some teaching. And Joe, you took my advice to heart, didn't you? Because this is a pretty harrowing first patient story about NSEC. So just talk to us a little bit about this. I think you can assume we've read it and we've absorbed it.
Thank you, Chair. Yeah, it is our commitment to bring both a mix of both positive and negative patient stories, and this is clearly the case. So this was, obviously people have read it, I'll just pull out the key points. So it's around waiting times, which we know, particularly the pressures that were talked about earlier, that waiting times are an issue. The patient in particular talks about the fact that understanding, even though there's a wait time where you are in the queue, why you're waiting as long as you can. I think that's described somewhat in the staff story, which I'll cover in a minute. They go between ED at NSEC and then the next day to ESTA. The key points there, I think, is that communication, so feeling a lack of continuity and information sharing between the two episodes of care, and the frustrations and the feeling, the attitude of the member of staff in terms of understanding why the patient was there. In a positive sense, they talk about the speed of triage, and there was pain management, which we talk a lot about, and the thoroughness of the exam, but I think overall it wasn't a good experience for the patient. They talk about some really key important areas around staff attitude, around information and consistency, and around the waiting times. If we move on to the staff story, it's a member of staff who has worked for the last 2 years in ED, talks about how much they enjoy working there, the variety, the learning that comes after a number of years in nursing, still that opportunity to learn. The challenges they describe marry up completely with what the patient talks about around volume, about understanding the complexities of cases that can come in, and sometimes in explaining to patients the wait times, because they talk about what's going on behind the scenes in terms of need, priority, etc. But absolutely acknowledge if there was a way of patients understanding where they were in the queue, that would help a lot for patient experience and also for staff experience in terms of in time. They absolutely feel the benefit of triage to patients, but also to staff and to the streaming service that we have on the front door in terms of getting our patients to the right place. And they talk about the need to improve our environment for patients with a mental health condition.
Thanks, Jan. Let's just start with the patient story. Anybody want to respond? I mean, obviously there was a difficult story there, and we don't need to respond so much to the details, but the learning from it, Ruth?
I think we've talked about this before, haven't we? That it's not so much what happens or what doesn't happen. It's about people's understanding of the time.
Yeah.
So if you know that you're waiting for something specifically, and you know there's a time scale, you accept that, and she makes that point, or whoever the patient is makes that point in the note. I think we're very busy and we forget that it's a person and it's a bad day. And if we just talk to them and tell them realistic expectations on time, I also think, for me, on a personal level, someone getting home at 6 a.m. and being told to present again before 2 p.m. the next day, when do you expect this person to sleep or recover or deal with their pain? So I think it's an information thing for me, probably more than it is anything else. It's not a great story, but I think it's that. We've got to remember the person behind it.
Hannah?
Yeah, it's a really powerful story, and there is lots.
I'm not hearing you very well, Hannah. Can you speak a bit closer?
Move it a bit closer. I think my reflection is the same as Ruth, that I think silence is as much of a problem as the waiting time, and silence creates fear and uncertainty and have I been forgotten. And I think there's something for me about how we can be transparent but also dynamic and perhaps be giving people a range of times, because it is constantly in a state of change. And I was at ESTEC this morning thinking about communications. I was there when it opened, and the patients are coming around for a meeting. They try not to pre-arrange or have patients accepted to make sure that actually the flow is as smooth and as quick as it can be. So we're going to reflect on some of this through the front door service meeting. But there's definitely for me something about transparency and how we can do that in a really dynamic way.
I think the point about information is so key right across patient experience, because when we look at when patient experience in the main is negative, predominantly it's around communication and information, and that consistency of both of those things, isn't it?
Margaret?
As with the colleagues, it's an incredibly powerful story. I just wondered about, when you're in this, the clinicians, obviously there's so much going on that you're not necessarily focusing on that one individual and what they're experiencing. So how do we feed that back to our clinicians that they can see and read this? You know, are we actually going down to the colleagues who are doing it, not just the business managers who then you're assuming will share, cascade that information down and improve the learning, but actually drilling down to some of these clinical staff. Some, really great story about the nursing system, but then the others not really that very good. So how do we do that?
Bishu, do you want to come in?
So they do, so remember this is one story, the big bar chart that we show every month. That has about 9-10 pages of free text that goes to this, all, not just the consultants, not just the heads of it, shared within the department, but all to read. I think with this, there is everything that everybody said here is absolutely correct. Our challenge is how do we communicate a message in an ever-changing, literally minute-by-minute changing environment. And I think that's the challenge that we have to accept, because by virtue of what comes in through the door, we can give a broad outline of, there's people in the waiting room, but there's people coming in through another entrance who are coming in by ambulance. That might tell you the numbers, because sometimes you hear in the anecdote, I was, numbered, there was 74 in the department, and it went to 100, and it had only been 5 minutes. I'm slightly exaggerating there on the numbers, clearly. But I think that then trying to explain, even though you've seen that increase, you might only have to wait another hour, or you might have to wait 5 hours, depending on what's come in. I think we have to think through how can we make that a much more dynamic process. And I think there's probably a few heads that needs to get round. It's not just our natural instinct is to say, well, the technology must be able to help us on that. I'm not sure it can do that as easily, because you can be fine 1 minute and the next minute we're pulling you into resus, and you're not. That isn't for everyone, but I just don't know how we balance some of that, which I think we probably need to go away and have a real think about.
You want to come back in?
Yeah, I do want to come back. I absolutely agree with you, we have a process, but are we assured that our clinical staff have the capacity and time to actually read that? Because when you read the next detail from the nurse, who's very clearly, very, very busy, they have not necessarily got the time to read this, and particularly if you're saying there's a bound of stories. So that is my worry, that individuals are not necessarily always getting that fed back to them.
Thank you, Jeremy, and then Richard.
So I definitely want to agree with all the comments about communication, but I think the point I want to make is that actually part of the problem is this patient was in a number of queues, and that is the problem. Not all of the queues are connected, and that one of the solutions to that, it isn't a complete solution, but one of the solutions to that is the front door process, to get the right patient at the right time. So if she had arrived, if ESTEC was the right place, and I can't help but read it and try and work out what the ideal pathway is, and I'm trying to resist that. But I think that is where, and she needed an ultrasound. I think that would have been much simpler than that. It is a difficult system for the staff to work in when for them to communicate across fragmented pathways as well. So I think we are onto something with the ANS system and the front door system. And we must remember that at least one of the things that we heard during that process was feedback from ESTEC and ambulatory care that the quality of the patient, they were getting the right patients at a better time in their pathway. And that will be really key for patient experience, because some of the problems that exhibit in there in a variable input and a variable output system are extremely tricky. When everybody in those three separate queues is extremely pressured, having lots of demands placed upon their time, and there won't be ideal systems. And you can read as much feedback as you like. These are the conditions in which we are trying to do our best, and the staff are trying to do our best. But it will be better if we try and think about what the fundamental issue is in this fragmentation.
Thank you, Richard, and then Andrew.
So it was a difficult read, I think particularly for me, because my experience of ESTEC has been unremittingly brilliant, and I think it's one of the jewels in the Trust's crown. It's not the first time I've come across transfers from other parts of the Trust into ESTEC not working, with incomplete or no information being passed, and a sort of almost left for the patient to know what it is they need to say. And I'm just wondering if we need a structural look at the way that people are referred from wards or from other parts of the network or from ED into ESTEC to make sure that ESTEC are pre-alerted to what it is and exactly what it is you want them to do, because it does seem that at best it's wasted a lot of people's time.
And do you just want to respond to that, Hannah, before I bring in Andrew?
I was going to make a different
Okay, you would go, Andrew.
I was just going to raise, I think it's important to talk about the kind of comms and the visibility of the time. And whenever I walk in, I always look at,
Yeah, me too.
and think, well, can these people in front of me actually interpret that? And we know they can't, and we've explained why it's a tricky one. But I just thought in this, as well as that kind of information angle in that sense, there is this kind of the thing about the ultrasound paperwork, which has been incredibly upsetting for the patient, and is also a massive sort of productivity problem when we get into that. And it just made me think of whether there are some things that are a bit more black and white that we could get into, where we try and make sure that those handovers, or get some insight into how often that's happening and how much we're kind of chasing our tails, fixing things like that when they happen.
That's a fair point. Hannah.
Just to go back to Margaret's earlier point, I don't know if this was in your inbox as well this morning, Joe, in terms of people reading the reports and digesting them and offering suggestions. So the first email I had this morning was from a junior member of staff who'd read one of the patient experience reports and said to come and put a fruit bowl in the paediatric waiting room in ED, and someone else, did you see that? No. Did we do this? They do this in another organisation. So people do read the emails and do feel comfortable in replying to everybody with suggestions. So I just thought it'd be good for everybody to hear that that is happening.
That's really helpful. Katie, then Marion, then I'm moving towards completion.
Thank you. Like everyone said, it's a very difficult story to read. I don't want this to be taken the wrong way, but for me, it's staff attitude really comes down to this. And I know they have incredibly busy, stressful jobs, but when you're reading about someone being dismissive, having no empathy, etc., I just don't want us to lose touch on that. Any system in place that works well isn't going to resolve an issue with staff attitude. I think it's just really important to pick up on that, because every patient is going to feel like they're the key patient of the day, and they need that empathy.
And maybe if I can just briefly say, because I've spoken about that this morning, this obviously isn't the place to talk about an individual case, but I have received assurance that that issue is being properly addressed in the normal channels. Then Marion.
Yeah. I couldn't agree more about that, and I know that it's been dealt with. And just really go back to Margaret, just about the staffing and the experience and things. You know, the business unit particularly have done a lot of work this year about the gaps, the staffing, the clinical skills, but also the notice. And the rota management in this kind of thing, I think, is absolutely pivotal to make sure that we've got that balance right. So just to reassure you about that. And the second point is, it is a fine line about the communication of the person. If the patient has been there a number of hours, to think, actually, can we just get that ultrasound done now and not get them to come back? But if the department is extremely busy and you're really stretched for space and things, then would you ask them to come back? But the bit of that is about the communication, and it goes back to Katie's point about the culture and the sensitivities. As soon as that lady came back, then they felt that actually they were at a hindrance because they didn't know about it, the documentation hadn't obviously been shared properly in the communication. So immediately, if somebody's pleasant to you, you will put up with a few things, even although you shouldn't, you do put up with them. But if somebody isn't, it immediately puts you at a very disadvantage. And it does get shared, as Hannah said, it does get shared, these kind of things with the team and also MS.
Good. Okay, that was a fruitful discussion, and important that we continue to hear these. Important also that we remind ourselves that we're getting all the real-time data and the satisfaction ratings, and we know as a result that this case is an outlier. But we also know that if we don't look at the outliers, then we don't ever get to the chance to be further improving. So thank you, and I've asked Jo, she will give me the information so that I can write to the patient story person, not as a formal response, but to thank them for articulating the issue to enable us to have this kind of discussion. I think we partly concluded that there is a linkage between what we've heard in the staff story, particularly about how it can be really stressful and whatever, and what we've seen in the patient story, where at times stressed staff have not delivered in the way that any of us would have hoped. And there's clearly a real cross there. We've picked up the importance of communication and finding a way, if we can, of improving it. I can't help feeling there are experts out there, and it's not our normal communications people, well, maybe. But I know myself when I'm on a system, I love it when I'm told I'm 7th in the queue. Well, I mean, I prefer if I'm 2nd in the queue, but I love being able to monitor it that way. And we haven't cracked it we haven't got that good yet. And maybe we can just explore, set up our aspirations. No, it will never be as precise. No, it might be, you're in, let me not try, but I think there's some work to be done, and there's some thinking and scratching our heads. Ultimately, though, there's still that issue that I think with Ruth Ken said that the beginning is for everybody to be recognising there's a person in there. I know that we know that. I know that it's incorporated in staff training, but it can kind of never be emphasised enough. And we've picked up a couple of concrete specifics about the transfers, about the way in which paperwork is transferred, particularly maybe around about the recording lab ultrasound. There's maybe some actually short-term, just things we could fix if we could get on with it. I just need reminding, Bishu, as to how do we get feedback on here? I mean, this isn't the process whereby we agree a series of 7 actions, because, it's for the executive to think through that. But this has been an important discussion, and I wouldn't want us to lose it, and at some point to get a reflection back when the executive has a chance to reflect and think.
We'll get back, if not to public board, to a session, whatever works.
Yeah, let's take offline, but we'll aim to get a little bit of feedback from there. But that was really, really helpful. Thank you very much, Jo, for bringing all that in. And it's still with Jo now as we go into the patient and staff experience, and this one feels a little bit more salient. And I mean, that's not a criticism, that's because I think our performance is staying fairly steady on this.
Yeah, just a few headlines. So inpatient, if we look across all our programmes, we see good performance, particularly around overall performance scores. NSEP as a site, so the emergency care hospital for inpatients is retained back into the top 20% when we benchmark against national inpatient performance. Our area for focus continues to be discharge and planning. Outpatient performance is extremely strong and continues to be. Emergency care overall, so that includes our UTCs and our emergency department, we remain within the top 20%, although we do see a continual historical decline since 2021. And our emergency department in NSEC continues to be below the top 20%, and in line with what we've just discussed. When we look at areas for improvement for ED in particular, it's around weight, pain management and information. Community, the overall satisfaction score was extremely strong, but when we look at the area for improvement, which is around 3% of people report a negative experience, when we go down a question level, we can see the involvement in decision making around my care is one of the areas for focus and improvement. That's as much as I'll say about patient experience. In terms of staff experience, we're obviously coming to the end, so tomorrow at midnight the National Staff Survey finishes. We've just got the latest figures. So as a trust, we're 72.1% of our staff have chosen to share their experiences and fill out the survey. Our bank staff are 40.9%, so just under 41%. And I am going to say we've got the battle of the titans, which is, in terms of hearing about our staff, is NHFM. Have now 81.2% and NPC are 81.1%. Rosie will be absolutely delighted. So I think it's amazing, particularly if you look at the trust. I've got a number, 6,500 staff have taken the decision to share their experience, and we're really pleased about that and hope we get a few more over the next 36 hours or so. And I think Rosie will be walking the corridors till midnight tomorrow.
Very good. Any questions or comments to Joe? I just appreciate the fact that in the medium-term planning, there's the aspiration that the government puts out that trust should be aiming to be getting real-time data from 5 wards by the end of the year. And here we are with real-time data from across the trust. Much to be proud of. Good. Thank you very much indeed. Then let's go into the board walkabouts. Interesting set. One, Margaret.
Thank you. I'll just take it as read. Really interesting and an incredibly busy, large outpatients department. One of the things that came across was meeting Denise, who was the ward manager but had been acting as manager for a while. Incredibly positive about the organisation, incredibly proud to introduce staff, to talk about the decoration. Patients seem to be sitting really calmly. It was very, very well run, but there is an issue around sickness in that particular area, and the importance of staff feeling that they have the agility and flexibility to be able to cover other particular areas. It was great to meet one of the spinal consultants, and he did talk about how his aspirations to develop and take the service further, but obviously the infrastructure was not there to maybe do some of his aspirations, and that's probably because Newcastle are known for being a big spine centre in the northern region. I think the other thing that hit me, and it's something that I've mentioned about PCC looking at, is your plaster clinics and your plaster technicians. Those colleagues were a lot older than other colleagues. They'd been there a very long time. They were very committed to the organisation, but they did have the highest secret records as well. And I just wondered what we could do within that particular area. It's typical, it's very typical. You know, many years ago, I ran something that had a lot of plaster technicians in there, so I understand it, but it's something I thought in the future you're probably going to have a problem, and it'd be really good to look at the apprenticeship agenda in there as well. I just thought it was a really positive visit, and I thought one of the things we also talked about is the complexities of dressings with some of the nursing staff, and just how the interface with the community staff and the importance of sharing some of the new treatments and approaches, and that was working really, really well. But obviously some of our patients were still having to come into outpatients for those dressings because they were more complex than your straightforward one. But overall, really, really positive. Thoroughly enjoyed it. And it was great to see, and I talked to quite a few staff, that they all felt this was a great organisation to work within, that they felt that they could identify any changes to improve the service, but also felt that they could raise any sort of concerns. So very positive.
Thank you very much indeed for that. Any questions or comments or challenges? Kate, I'm assuming...
Yeah, just to say that we'll pick
Yes.
that up now, but thank you.
Good. Any more on that? I do enjoy these sessions. It feels like it brings to life areas within the trust, so thank you. Andrew, your report, we actually had a chance to talk about it at IMT as well, didn't we? So,
Yeah, so I was so happy with this, and especially IMT. I wanted to mention it at IMT committee because some of them won't hear at Trust Board, so I did want to say well done to them. I left glowing after Marion and I went round. We had a really good visit, and we went to Ward 25 and Ward 7, and we focused on those because they were where the nerve centre EPMA, so that's electronic prescribing and medicines administration, so replacement for e-meds had been rolled out about a month before then. So I was especially interested in hearing how they got on, but also just to look at the sort of general surgery and kind of pick up on how they were doing. So we went round Ward 25 first, which was looking fantastic. I think that layout now is working really well. We bumped into Elliot in action, which was good, and he'll probably mention it later, but I think it looked like it was working really well, and there was something really awesome came out of that about moving people backwards and forwards between Inspec and North Tyneside, which I think is kind of a hard step to take for some of them, but then a lot of people were saying that they'd learned an awful lot about sort of seeing the other side, and you could hear from the way they were talking about it that those sort of relationships that they have on the other side helped them pick up the phone when something wasn't working or didn't feel right, or it felt like that was working really well, so it felt like it was worth the, I don't want to say worth the pain, but worth the disruption of actually doing that from people who kind of maybe become a bit entrenched on one side or other side of the fence, so that was working really well. We kept asking for, you know, what would you like to tell us about what's not going so well? And I really couldn't think of much, so I'm really pleased. There's just this question about, they've gone from 2 domestics down to 1 in the mornings, and that is a huge ward. And just in the conversation, it was spotless, I should say. They were obviously working really hard, and I wouldn't pick up any complaints about it, but it's just there's 1 domestic who's there doing 23 rooms, 17 toilets. It's a lot for 1 human being to stay on top of, and so they were wondering, you know, whether it was right to go from 2 domestics down to just 1. On the nerve centre rollout, I was really digging on that because they were kind of going, "Oh yeah, this was brilliant." And hey, tell me what went wrong. Tell me how horrible it was, because it was a really difficult project, and we talked to IMT committee just before the rollout, and very focused. I wouldn't say nervous, but especially Karen Conley had done a massive amount of work on getting people engaged in the training and understanding what was about to happen in the rollout plan. So we were happy there was a good plan, but we worked hard on it and we weren't taking it for granted it was going to work, and the staff were incredibly positive about it. So lots of feedback like, "Oh, I can do this on my mobile device now, I had to go and get a computer to do it before," and the comments I really liked was there's lots of little things that are better now, so I thought that's really positive. So I was really pleased about that. And when we got toward 7, Julie there was similarly glowing because you know, she was sort of saying, "Oh, well, you know, we knew exactly what was coming because we've been involved in designing this," and I just thought this was a really difficult project and lots of evidence of doing that really, really well. So I think the involvement was really good there, and the team being visible around the go live really came through. So I wanted to say a big well done to the team that had worked on that. I think they really need to be congratulated. It's kind of the culmination of many years of getting better and better at this, so I was really pleased about that.
how nice that you can bring that walkabout to your last board meeting. A positive example of where strategic investment is proving really beneficial. Marion, anything you want to add to that?
Yes, it was a good meeting. We hadn't preempted anything, we didn't know that we were coming, and they didn't know we were certainly going to be talking about all the IT stuff. Just one point to raise, the domestic situation's been sorted. It was sorted that week. It's still a wee bit tenuous, but they're definitely on it. And then the only other thing, just to go back to Margaret's point, was that we have started a review of the plaster text. That's already in hand, so we'll get that and we'll work with the team because we do need to think about the succession planning. So it's really good to get these board walkabouts because you do hear from the teams, and I think they're very good. There's no hold bar. They are keen to say if there's a problem, but then I thought it was really nice because I think they were very expressive in the way that they said that they had been included in all the EPME stuff, and that makes a big difference.
Yeah.
Yesterday at our meeting of NEDS, it came up that the board walkabout reports aren't always circulated back. Have we sorted that now?
Yeah, we'll add in a named contact when we ask the execs, and then we'll make sure that feedback goes back to that named contact on the board.
Because I'd always quietly assumed that happened, so I'm delighted that now it will do. Andrew?
Can I just flag one thing for a follow-up that I just mentioned? So one thing that was really good on the domestics was they were telling us that they were picking it up. They weren't kind of asking Marion to solve it. No, they were already on it. So I thought that was really positive. One thing that we did pick up on, which I'm not sure will get picked up through another group, was around how long it takes to get blood results back. We were hearing about Ward 7, and they were sort of saying because of their pattern of work, and now, so I haven't fully caught up with where we're at on the process, but because we run out with blood analyzer only twice a day, if they miss the first cut-off point, they feel like they're waiting hours for blood tests, so they were sort of saying, well, this new improved service isn't actually better for us. I just thought there was something to pick up on there to see how that was working.
I'll pick up that now that that's part of my area as well.
That's great. And that's a couple of nice examples. It's not for board to resolve issues about one or two domestics, but flowing up an issue like that is reassuring for us. I think the executive then take it on and think about it. But Phil.
It was just to mention the other thing we discussed on the walkabout reports was to have a better evidence system of where points are raised, what then subsequently happens as a follow-up. We often have the discussions, but it's about maybe making sure there's more of a trail of the points and the action.
Yeah, good. We're following that up. That's good. Thank you very much indeed. Then we're into the Wallsend Health Centre, and in Steve's absence, Hannah, do you want to bring it to life?
I accompanied Steve and visiting the base site for the Community Learning Disability team and their
Just move close to the mic. You've got a really gentle voice.
I've never heard that before. Is that better?
Yeah.
The team are housed in Wallsend Health Centre and they serve adults and children in North Tyneside, but not Northumberland. That service is provided by CNTW. And we met almost all members of a really large, diverse centre. And they conveyed real pride in the services that they provided, how they looked after one another physically with health and wellbeing checks. And if people were out lone working, psychologically with clinical supervision, they have a bring your dog to work scheme that they thoroughly enjoy. We met the puppy that was on site that day. It's a very holistic service for patients, and it's clear how much the team care for the patients that they're serving and how they often see them at multiple times through their life cycle. So they'll engage, there'll be a period where they don't see the individuals and then they'll re-engage later on. So they see them grow up and spoke with real pride and passion about that. Steve referenced in the report that the environment isn't great. Not great for staff really. Patients are very rarely seen there, but it is a listed building, so there's issues around heat retention. We met a fixed-term educator who fixed-term funding for an educator role, and she's offering autism training supported by the Lawnmowers Theatre Company, and I don't know if anyone's experienced that, but she said it's really well received. We explored quite a lot how that fitted in with the Oliver McGowan training, and she felt that was an enhanced version, but clearly not feasible for us to deliver across the entire organisation. And so on the whole, as Steve said, a really inspiring visit, really valuable, and just showcase some of the vast scope of services that we provide in Northumbria.
That's great. Thank you very much indeed, Hannah. Any questions will come up? Thank you. Then our last one, Katie.
Yeah, thank you. Really mixed emotions when we did this walkabout. So it was around the mortuary, North Tyneside. The team were phenomenal, and we both left inspired, so good, proud of what they do. Before I'd met with the team, I had no idea what an APT is, didn't even know the role. So I still have to read it now, anatomical pathology technician. I had no idea what that role was or what they did, or the vast mix of things they do, and it's incredibly difficult. It goes from cleaning up to dealing with family members who just going through bereavement to talking to police to, such a mix of skill. What was wonderful is just to see how they enjoyed their job, and they were quite embarrassed saying that they were enjoying their role, but it was just wonderful to hear. And what was so lovely is how they saw it as just a stage in life. So all of the bodies that were there in the fridge were still patients, and they were still talking about them as individuals, and it was just wonderful to hear. A few bits we picked up on, there's been quite a lot of change with the team, so it's just been staff restructuring. They've got an IT system which didn't fall on them too well, but I think they're quite pleased with the system now, so it reduces the volume of paper work that they have to do. Where they sit, there's no natural light, it's not conducive to working there long hours. I wouldn't be comfortable working there, so I just think we need to rethink how tidy it is for the staff members. They did mention about there's an increase in baby and young person deaths, and therefore there may be a need for further APTs. There are 2 apprentices coming through now, which is great. Upgrade of the system as well, so recording of post-mortems is still done via paperwork, so how we think of updating that. And then they've got the fuller review recommendations coming through, so I think it'd be good to get assurance about how that gap analysis is being reviewed. But it was, a wonderful visit, and I think we're off on Monday after to see some more pathology team as well.
Terrific, and terrific in particular that we're visiting the kind of the lost corners of the trust, or they can be lost if we don't watch out. So I'm really glad that the team has been arranging for these kinds of places to be part of our tourist plan.
So it was great for me too, because obviously with changing areas, that was my first visit back after 20 years. So it was really, really great to see all the positive things that happened in that time. It's still in the same space, it's been altered accordingly. It's good.
Yeah. Good, any questions or comments? Excellent, well that was a rich set of discussions, I felt, so I'm grateful to you all. Let's move on now. We've got under the performance strategy section the opportunity to get an update from one of the business units, and it's medicine and emergency care's turn. Simon, are you kicking us off?
Yes, thank you. So there's at least one new face in the room. So I'm Sam Eaton, I'm the business unit director of medicine and emergency care.
And I'm Beth Bowden, I'm deputy director of medicine and emergency care.
So we're going to do a little bit of a double header, so thank you for inviting us to provide the update regarding the medicine and emergency care business unit. We always start with this slide because it's very important for us to mention just kind of the size and the breadth of the business unit. Very often we're talking about the emergency care stream, if you like, and people are very mindful of the ologies and all those sorts of things, but there's a lot of other services that again can get forgotten or overlooked, but are very, very important to everything we provide as an organisation to our population. So just as a reminder for that. And what we're going to do now is a little bit of a double header. That's going to do all the difficult data slides, and I'll round up at the end.
So just to have the slide back, but just a bit of an update on kind of a few key areas for us. So we remain strong around elective performance, particularly around 18 weeks. We have a few areas that we're working on around appointment slot issues, so ASIs, where we just need to work on our access pathways a little bit to improve that further. That's cardiology, rheumatology, respiratory. Rheumatology is particularly an area that we've got capacity issues with. We've seen an increase in both referrals and advice and guidance significantly into that team. There is a hope that the advice and guidance will kind of stabilise and level off a little bit, but we're not seeing that at the moment. So we're putting some additional support into there, and we're looking at some pathway changes around cardiology and respiratory to see whether we can just kind of reduce some of those slot issues and change some of our clinic templates as well in those services. So we should start to see those improve over the next few months. We're on track around elective kind of performance in the sense of kind of ERF. There's a couple of areas obviously at risk, but we continually review those within there, but overall we're doing well. We continue to review from an outcomes and an outcome form point of view, and there's a piece of work going on with the Hanson team at the moment. The next set of slides is around our urgent and emergency kind of stream and pathways, and a lot of them you'll be very familiar with and seen them in other settings. As you're aware, ambulance handovers remain a key focus for us, and we've had lots of improvement work within that team and department, and they're doing really well. But it's a continued focus and a continual effort to keep things on track. Obviously, the pressure in the department, pressure in the system has a knock-on effect on this, so it's something that we have to work on an absolutely hourly basis and on a daily basis, and I know that that was in the discussion in the field earlier this week as well. Emergency department, again, around performance, it's just as a comparison to where we were last year. The last couple of months we're not quite, October particularly, September, not quite hit the plan, but in comparison against last year, we've kind of remained on track and slightly better in performance, whilst not where we want it to be. November to date so far we're at 89%. We've got a few days left, and we're trying to kind of make sure we maintain that to the end of November.
We all noted that. Yeah.
And again, I know everyone's we discussed this in detail, and we had the opportunity to come a couple of weeks ago to talk about our urgent treatment centres and front door services. Again, you'll be used to this data. We've seen significant increase in the urgent treatment centres, and the demand in there, and there's, as you're aware, there's a piece of work gone in and review it about increasing the staffing to support, particularly North Tyneside and Lonsbeck, to help the team and help make sure we see the people in the right place and locally, but also to help in that kind of front door and getting people to the right to help us maintain a really functional front door service, which, as you can see, and I know we talked about a couple of weeks ago, we're in the process of trying to ensure that's robust and get it into a place that we've got sustainable staffing and it's funded appropriately. But I know again that's something that you're aware of, and it's on track to coming into in December. We're performing well from a workforce point of view, in the sense of our sickness rates, and all our staff and mandatory training, etc., are on track and on target, and that's maintained since the last few months I've been back. It's a really positive set of data within the business unit. The teams work really hard to maintain that, and obviously maintain low sickness absence as best we can, to support the wards and departments. And then staff experience. There's a few key areas that we wanted to do a bit of work with. ED is one of them, actually to come up in the last few rounds of meetings I've had with the staff, and that's something we'll look at. But at the minute, obviously, we're looking at our staff survey. I think we've just hit as a business unit 70% return for medicine, which is great, but there's a few areas we're just under focus there. There's one particular area that's not quite at 50% that we're just doing a little bit of work with over the next couple of days, just to see if we can improve some return rates on there.
So thank you, Beth. So essentially, I guess medicine business unit in summary is a bit like it's been in the past. Our school report being, well, we're doing pretty well, but we've always got things we need to improve on. We're always looking to improve and take things a little bit further. There are a number of things we've just picked out on the next couple of slides. I'm not going to go through as well. You'd be delighted to know around key achievements, things that we're very proud of. I think the last bullet point I personally want to say how brilliant it is to have a proper leadership team now with Beth and Hannah as part of it as well, and things that are making progress now that have been a struggle over the summer, things like that. So really grateful to that. And we've got a lot of services that we're very proud of, again, the work that they're doing and trying to improve. One of the, I guess, just picking out the emergency department, people are very aware that they got the Chief Executive Award, the Staff Awards, about what the leadership they've been showing through the nursing staff in particular, senior nursing staff in the ED, that had been delivering some very good improvements around ambulance handover, dropped off in the last month or so, mainly about my pressure in the system, the constant message is the people that are working in our teams that are delivering this all of the time, and we just need to do what we can to support them to keep on delivering the great stuff that they do.
Just back the slide, they're all 25, 26, aren't they? Rather than 24, 25. Yeah, it seems.
Yes.
That's right. Thank you. Just wanted to check.
No, these are things that so these are things that we have done in the last year.
The previous year.
This is our ambitions for the next year.
Next year that we're almost finished.
So 20.
Okay, take it offline. I think it's
things we're proud of to date. Okay, and then looking forwards from here, similar things to what we've had before, continuing to work on just trying to, the staff experience data from the surveys validates the surveys. If medicine was coming out going, yeah, everything's fine, then we would really struggle. Well, what on earth are we measuring? We know that our teams, particularly in the emergency and urgent care system, but right across, are facing pressures all of the time. And we need to look after them, we need to pick up on as Beth was saying, all those areas where things aren't quite going so well, and really try and work on trying to improve things for them. Constantly trying to look at our patient experience and making sure that we're improving that, and trying to stay as diligent around the money as we possibly can do. That whole set of things is defining how we think and work. Obviously the emergency system, obviously our elective performance as well, but then wanting to make sure that individual services are moving forwards, think about where next, what innovative things we need to do, so we're not resting our laurels. And over the years, I think the UTCs is something that's fallen a little bit back into the background, but is very prominent in our thinking now, and it is hugely, is a massive provider of care on a daily basis to patients across the patch. So our summary, and people will spot this does look remarkable. We've changed it a little bit last time, but it's the same sort of message that we are proud of what we're delivering, but we've still got lots to do and improve upon. Winter is always a pressure right across the organisation, but particularly for medicine. But we've learned a huge amount from last winter and are trying to put those changes or improvements into action to try and get into a better position. It's always going to be a pressured time. And there's lots of opportunities into the future to continue to take things forward. But if I've not said it before, I'll say it again, it's the teams that are amazing and that we look after, and that's our biggest challenge and our biggest drive. Thank you.
Excellent, and sorry for distracting you on the irrelevancy of the dates. Comments, Chris first of all.
Yeah. Thank you. Just to pick up on the referral to treatment slide you've got in there, I think you've done these slides before we had October's performance. When you look at October's performance, it's gone up to 97%, so it continues to increase, which is, I think, probably, well, it's phenomenal. It's probably better than I would have thought. Just a couple of points on that I'll comment. The first one is kind of that link back to urgent emergency care, that we always link if you've got good elective access, actually then does that have a positive impact in terms of people getting treatment and care in elective stream rather than coming through front doors here or treatment centres. And I guess the second more question is around hearing comments from colleagues across the region around GPs being more aware about waiting times across the patch. So when we've got fantastic access waiting times for elective care, are we kind of prepared? Are we kind of still looking around? Actually, we might be getting referrals in from other areas that we're not used to, and kind of just how sort of planning to keep an eye on kind of referral rates and make sure our access still is maintained at a really, really high level.
So I know particularly rheumatology sees referrals from, so even though it's one of our most pressured areas and has long waits, and then kind of all the other services, it's still very good waiting times across the region, so we do see referrals from other areas into there, and particularly around Newcastle. And that's a challenge that kind of adds to the picture.
I think on Chris's point as well, when you look at the UTC activity as well, particularly North Tyneside UTC rather than Wansbeck, we've seen a shift in activity, postcode activity. Now, it could be that they happen to have their accident or whatever in the North Tyneside, but generally if we make an assumption, we are seeing that shift.
Okay. A lot of this has gone through FIP in some detail. Are there any points, Phil, you want to highlight for us? Don't need to.
No, it was just to say, yes, we did have a separate discussion on the ambulance handover movements and the various things that we're doing, particularly with partners at NIAS, that will be into some of the issues, not least this ongoing discrepancy between our two different readings of performance, which it would be helpful to get closer together. But just rest assured that there's action being taken to get things back on track.
Okay,
I suppose it was 2 points. One is that I think particularly through rheumatology and one or two specialties, that I think we are seeing more clinical pushback by specialties in Newcastle back to ourselves, so that patients who previously may have chosen to go to Newcastle are being redirected back to us, so we are getting probably additional pressure as a consequence of that, and we probably need to monitor it, because I'm slightly uneasy that that may be counter to patient choice, because services are not geographically defined in terms of secondary care. Community services are. So I think that's one. And the second bit was, there is also, I think, particularly for rheumatology, that there's an absence really of any regional commission pathway for several key conditions, fibromyalgia, hypermobility, ehlers-Danlos, which are difficult conditions, and I suspect a number of advice and guidance or pressures on the services then for a service that actually doesn't exist. And that creates frustration for the public and clinicians as well. And that probably does need to be raised, I suppose, regionally, because I think we are picking up more activity which we can't answer. I'm all for us answering and being responsive where it's in our gift, but some of this isn't, and I guess that might be something that may particularly be contributing to rheumatology.
This issue about patients from particularly Newcastle, but presumably not only, coming here, is this a significant problem? I mean, you've indicated it may be a patient choice issue, but in terms of what's the right service for patients, do we worry about this, or do we?
I think there's soft evidence that there are many more patients being bounced from one organisation into another, realistically, which makes no clinical sense.
Because if it made clinical sense, then that would be positive. But if it's not clinical sense, then this is an alliance issue that we need to try and start.
I'm certainly, I think a lot of GPs are seeing, Newcastle asking to be referred to, a patient under Newcastle being asked to then have additional care being provided by Northumbria, which doesn't really make sense, particularly when they've got a long-term condition that is also being managed by Newcastle.
It's maybe an alliance issue we need to consider. Thank you. Jeremy.
So I think there are two issues. I think there's definitely the Newcastle issue, and that's for one set of reasons. And I mean, historically, so there are a number of patients who travel from Whitehaven to receive their rheumatology care in Exton. There's a very, very well-trodden path around the back from Consett in County Durham and Darlington that is largely, I think, driven by waits and a lack of access to the services there. Some of that is because we're good at what we do, and they find it worthwhile to do. There is a choice agenda. I think one is patients choosing us, and the other is more of a different postcode issue that I think might be helped if PBR comes back next week.
I suspect this is an issue. Sorry,
No.
Okay. This is an issue we need to consider a little bit further somewhere, maybe in board development, where we can just look at some of the wider data, because, but crudely, if we are really effective, and as a consequence, if people patients for across a wider patch are wanting to access our services, then yes, we could close the doors and say you need to go back to Durham. Actually, we can't really, can we? But we need to think about the implications of this, and if that means we need to be planning for growth of services, as long as there's some income stream to follow, then that's what we should be doing.
I think there's something as well. I think you're right, we probably need to have a bit more of a deeper dive in this all. And I think there is something about trying to get actual numbers, if possible, for primary care. Because I think when we start to look at secondary care data, it would be tit for tat. Whereas I think here, this is where primary care, they're saying, we're just referring for this reason. There's no loss or gain for primary care. They just want the patient to see them. And I think that's the bit that will probably be helpful to try and get a bit of information as to what primary care believe their access routes in or out on. I think the thing we have to be mindful of all of this, and this is for all organisations, is that patient choice. Patients can go and request to go wherever they want to be seen. Yeah. So I think as long as the service is delivered in that organisation, so I think we have to be, when we're having these discussions, we have to be really mindful it is almost irrelevant. If somebody from County Durham and Darlington wants to have their care over here, they're very much entitled to have their care over here, be that through the elective route or through the emergency route.
And I have to say, from a couple of neighbouring trusts with which I have a relationship, at board level I hear very similar about people from outside coming in. It may not be, I'm sure there is a tit for tat element, whether it absolutely balances, but this is across the system, it's not a Northumbria specific issue. Paul.
I think what may have clouded the issue is the imposition of block contracts across organisations. Clearly that will change in the coming year and move back to more activity-based contracts.
So put crudely, under the new arrangements, if more patients come to us, there is potentially more income for enablers to deliver their services to them.
Yeah. For the elective.
Yeah, for the elective.
I'm not elected to so next.
Ruth.
I just want to pick up on the urgent treatment centres, because that growth volume is enormous, isn't it? We're talking about a third at Wansbeck in 2 years, 25% North Tyneside. And how much we understand about that volume. So is it similar experience in all NHS trusts, or are we just very unlucky that people like to come to urgent care? It doesn't seem to be streaming out of NSEC, because that's quite a small number when you look at the streaming back to urgent care. So is it that we've got a sicker population? Is it that we've got a less robust population? Is it that we've got an issue with where else they would otherwise get services? I'm just trying to get my head around that massive growth.
I watched Alistair nod every time you asked a question. There's been a change from a minor injury to minor illness being a much more predominant part of the things. So that's presumably, you could think of it as primary care patients. Quite how much of it is genuine primary care access and how much of it is, I just can't be bothered, I'll just go down there and we don't know, but in a sense it's what public are doing. The public are turning up and it's certainly in the UTC settings on the whole we're obliged to try and provide what we can in that setting. It may, trying to change it is one thing, but actually ultimately we may just need to respond.
I think that was it, just understanding, because if it is the way the public is going, we can't do anything about it, we're not turning them away, but we've got to understand what it is that how we react to that. And I always come back to, because the feedback with governors is, we can't get in the GP, and I don't understand how much of that is the case, or if it's just that we are a now culture and everybody wants everything right away. I have children of an age and they do not understand the concept of waiting for anything. So is it that we're trying to manage?
They are planning a comms campaign to try and re-clarify exactly what the UTCs are there for. So I think we've got clear about what this building's for, but actually I think people just turn up with lots of things, I haven't had my diabetes checked for a while, etc. And just be really clear that is not what we do here, and we can't provide the care that you need in a 10-15 minute acute slot with a person.
I think there's something, and it comes into Margaret's walk, it was in your walkabout as well. It's also being used for things that are, going to say, inappropriate. So dressings, I'll come back to get my dressing changed. That's not what a UTC is for. So I think there may be an opportunity to say, well, actually, we can carve that out to a dressings clinic. We need to think who's going to run that dressings clinic. It's not part of the UTC workload, so there are things that I think have probably just grown naturally shifted into there because it's open. And in the same way, in the other example, the only place that is open 24/7 is the ED. Even our SDEC isn't open 24/7. So where all else fails, that is where you would default to. Or if I want to see, and I want to be seen now, that is the only place that can accommodate that. And I think we are not in a position currently to have all of our services open 24/7, which would spread the load. And I think that's probably a crux of the issue here. And we live in a 24/7 society now.
I've got Jeremy, then Alistair, then Phil.
So I just wanted to bring us back to vaccination because it's about convenience and opportunity. It's absolutely about that, and we will spend a lot of time thinking about how we could design our services, particularly, I hope, if we become an IHO and could talk to community providers, how we do it in partnership. But there is no doubt that the idea of something that is easy access and convenient to get to, you can get an appointment very quickly, will be something that the urgent and emergency care treatment centre, will need. They are here to stay. They're very popular. And I think that's what we need to do, is we need to make sure they're appropriately built and resourced.
It's probably a mixture of points. I think the first is our population, if you go to pre-COVID, is significantly older, frailer, and actually there will be more activity. I wouldn't discount the fact that streaming has an impact. 20 patients a day, compounded over a month, is going to be several hundred, which will contribute to these figures. So actually that is going to be a factor, particularly when these are monthly figures. So you could easily expect 500 patients extra a month because they're streamed. I think primary care is a factor, but I also think primary care, the evidence is that they're offering more appointments as well. So it's not as if things are static. I think we've got a general system where demand in its multiple forms is to a degree outstripping supply. But we also have duplication, which is probably a subtler factor and may go back to the IHO. A large number of these patients are seen in UTCs and then seen by their GP within 48 hours. The same as we track paediatric admissions or contacts where they will have a UTC contact, a paediatric contact and a GP contact all within the space of a week, normally for the same issue. So there is a bit where we're all running faster, but not necessarily entirely giving the unilateral one outcome that the patients need.
Phil?
It was just a reflection on Ruth's comment about the increasing demand of UTCs. And do we have a sort of an equivalent front door streaming service in UTCs at all?
We do,
so we do triage and stream from front door.
Do we send people elsewhere?
Yeah.
We do.
Yeah.
So even with that, it's still.
It's again, because we have to provide like a kind of a walk-in, and we've got GPs alongside you, so we've got minor illness, minor injury, but we would, if it was somebody that could go to a pharmacy, etc., then we have a streamer there for that reason. Also, for if someone needs to come to NSEC and they're in the wrong place, we would do that.
It's a really tricky one, that, isn't it? Because the UTCs are the non-urgent emergency default. And
but if we are
to
getting
turn people away to what? I think that's the point. There's no.
Need to build something.
Yeah, it's a population question, isn't it? And I think some of it is a population answer. I did speak to Julian separately a few months ago about this consistency of messaging, because actually if you go on the website, we burn the different things. What we say you should turn up to UTC for in Berwick is different to what we say in Hexham. And so we did talk about that standardising, because I think I don't think it'll change anything. But I think it kind of helps us to all point at the same thing. So this is what you come for.
This has been a really interesting and wide-ranging discussion. I have a sense that some of it, maybe even a lot of it, we've touched on previously in previous discussions. We keep coming back to some of these issues about our changing population and whether we've got the right model for delivery and whether patients are choosing in a way that is not quite as convenient to us as we would like it to be. And every now and again we take steps, so we agreed in outline a business case for doing some further work around UTCs just very recently. I can't remember when it's coming formally to board for it.
It's coming.
Going to Sandwich, okay, yeah. So it's not like we're not taking any action on this, but I still have this nagging feeling that there's another discussion to be had. It may be as part of the IHO, which I prefer to think of as IHC, Integrated Health Contract discussions. I would really like to get a sense of where we think we might be in 5 years, or indeed more to the point where we would like to be. Because at the moment I somewhat feel we're being buffeted by changes of which we're not in control, and some of them are demographic factors and some of them are patient choices, and we always will be buffeted to an extent. But I wouldn't mind getting on the front foot a little bit more and having a really clear picture of where we would want to be in this territory in the next 5 years.
I think you've hit the nail on the head there, Paul, because I think when we start to think about what inverted commas a neighbourhood would look like, and a neighbourhood around urgent emergency care, and we start to talk about cost base and how we move cost base from somewhere like NSEC more out into the community and what that would look like, I think that does bring us to what is our UTC in that context. And then what it is now versus what it could be in the future, and or should it be something completely different, and can we reduce the cost base again by moving out more into a primary care arrangement, or actually that's a step too far, and do you if you have a gradation of hospital UTC primary care, as actually in this instance is a UTC a better neighbourhood construct to upskill and increase capacity in there. I think that's the kind of conversations we need to start to think about, particularly for, I'm going to say urgent street versus the more planned long-term condition type work that you need continuity of care on, in particular within primary care. So I think there's a much broader conversation that's needed around who is best placed to do what and how much of an impact if you're under one IHO, IHC, whether that when you take money out of the question a little bit, whether what that model then becomes to look like.
Okay, I'm not going to try and summarise the discussion other than to capture that last point, which is I think it's been a rich discussion and you've been triggered by your work. So first of all, thank you for the presentations and as ever for the work that you're doing. But let's just try and schedule at some point another more visionary. It can be hard when you're running it day to day, and your team is really good at thinking about where we need to be over the next 6 months and whatever. And I just feel the need for us to extend the line of sight and have a discussion somewhere at some point. And that requires some really heavy brain space, and that may not be available to you guys over the next 2-3 months. But as we move into the IHC discussions, we need to make sure that we're getting a really clear picture, because I believe it's going to be part of the vision that we're going to want to set out as to why do we want to have greater control over the health budget in our area, because we want to be able to change it. And if we want to be able to change it, we need to have a clearer picture in this area. So I'm not asking for something next month, but I think actually, we'll be talking later about the kind of the schedules for integrated health contracts. We need to build this in. Thank you, that was a terrific discussion and really helpful. Still running straight on. Chris, you and exec are refreshing the Trust Big Signals and values.
Yeah, thank you. So this cake I'm just presenting, let's say, on behalf of the exec team that have been working on this proposal. I know we've been through board development. Yeah. So just in summary, a lot of work going on at the minute, as the board will be aware, around the new 5-year operational plan, the medium-term plan, around the 10-year plan, and also links into work we've been doing, or been helped to do by Virginia Mason in the recent trip over there. So it's really quite timely and to take the opportunity to try and update and refresh the values and big signals that the Trust has. So we've been quite extensively talked to our staff around our current set of values and big signals, and the kind of key message coming back was that they liked them in principle, but they were too numerous and too hard to remember, that like the underlying themes of them. So we've developed a proposal that we've seen in the papers there in terms of just to try and simplify the values and the big signals. So in terms of the values, going from 5 values down to 3, and then the big signals from 8 to 4, whilst keeping the kind of the broad themes and kind of what we were told by our staff that they like of those values and big signals. So the proposed refresh values signals there are there for you to see, and it's just to ask the board if they are comfortable with us changing and refreshing.
Very good, thank you. Thank you, Chris. And this is growing, you will recall, out of a lengthy discussion we had at Board Development, where we also recognised that if we're going to adjust the values, that is very much a full board, public board issue. So this is brought, I'm not wanting to say don't bring up new issues, but we have chewed over this collectively together beforehand. So with that intro, Kate.
Thank you. It was just to say that when we've been socialising these values, we've had nothing but good feedback on them in terms of staff being able to remember them and being able to associate to them as well. And I think you might remember at Board Development that talked about having a compact of behaviours under each value. So again, we've been doing lots of work with staff, focus groups, boards around what that looks like in terms of what we can expect of people and what they can expect from us. So that will sit underneath these values and be really clear to all our staff about what that means for them. But I just wanted to reiterate that people really like them, had really good feedback.
Good, Ross?
Yeah, just to kind of reiterate what Kate said, we've had a real good socialise on them in terms of the work we do with staff, and I was with Bijou on most of our roadshows as well. We were talking about it quite extensively, and there's been, I think, a lot of thoughts gone into it and tossed it around quite a lot, and we've had some really good feedback, so it feels like we're in the right direction from our perspective.
Very good. As we move from 8 big signals to the proposed 4 big signals, are there any bits that we're worried are missed out? Any elements that we can't naturally fit?
Sorry, I think that on that, there are 4 big headlines, so that is for what a majority of our staff can remember. Underneath all of those, we will still have an estates, a deep dive into what it means for our estates, a deep dive in terms of what it means for digital, a deep dive in terms of what it means under our for our people strategy. So the 4 big signals are very much the broad headlines.
I'm noticing in 2 items time we're looking at net zero, and that in the 8 signals it's actually named in relation to climate change. In the 4, I'm assuming it fits within services for the future or something, so it will appear as a second here, just an example. Good. Okay, any questions or challenges, or are we ready to accept the refresh of the values in the big signals? We are ready so to accept. Thank you very much indeed. Thanks, Chris. Then we're on to community promise. We always rather enjoy this section, don't we? Ruth Hammer.
Chair, I think that Ross wanted to...
Oh, sorry, Ross. I beg your pardon.
That's okay. I was just going to say I had the wrong name. We've got
I'm so sorry.
But, I know everyone was really proud of it. It's a real USP, I think, for the Trust, and there's been a lot of it from an alliance perspective, but also around the country, and Wayne and I have spoken at various events and things, and this idea of an anchor institution and really kind of being a solid part of your community, I think is one that's grown in lots of the IHO discussions and some of the other stuff we've talked about too. Now reports into the relevant committees for each strand, and it's been a little while since Wayne came, so he's going to give an overview along with Ruth as well about some of the key achievements so far.
Thank you.
So, Chair, thank you very much, and thank you for the invitation to attend this public board. The question, I think, for us here to present in today's public board is, for our communities, is are we keeping our promise, our community promise? So hopefully over the next few minutes, the presentation that Ruth and I are doing will give some assurance to board, but also to our wider public about the work that we're doing as an organisation. And again, just a very quick reminder, we're the first NHS trust in the country to make a formal commitment to our social value through the community promise, independently validated in terms of what we're doing. And it is that kind of virtuous circle of economic development. It is around our employment, it is around our procurement, it is around how we actually bring people into the organisation and nurture and develop them. And again, the big thing is around finding our future talent. So before I bring Ruth in, just a quick reminder there that we have 5 key strategic pillars around inequalities, education, employment, economy, and the environment. So what I would like to do is, based on that, are we keeping our promise methodology is to bring in Ruth to cover in on education and employment, and then I'll cover on some of the other pillars if that's all right, Chair. So over to Ruth.
Thanks, Wayne. So I'm going to focus on employment and education for you this morning. You can see there some of our information that we've gathered over the last couple of years of work regarding the Community Promise, our widening participation activity, including apprenticeships, and how we work with our public health team to look at our areas that have the most need for support with helping not only young people, but also the people that are providing information, advice and guidance to those communities to help them with considering employment opportunities and training that sits alongside that. It's all very much around a community and a system approach to this work. We've got some updates on our information regarding staff with a disability. So we're currently now at 6.43% of our staff that have a registered disability, and the NHS average is 5.7%. So, we're starting to see the benefits of our work that we're doing in supporting not only recruiting but retaining our staff with a disability. And that links through to the work that the North East Combined Authority are doing and helping people get into employment. And again, working with the NECA and the ICB on that work that Dan Jackson's leading on. From the Community Promise from an education, again, for those with the right information of numbers, you can see some of the work activity, the work experience. You can see we receive a lot of applications for that. We can't meet them all, but again, that links into where we can work with our teams across all the business units, including those in the community and the state's facilities, where we can offer meaningful work experience and placements. The T levels are the new qualification that's equivalent to 3 A levels. Again, these have been ramped up by government and offering placements for those. We've now got some in marketing, we've got one in marketing and comms team, we've got one in digital. So we're growing all the time and thinking to the future. Some of the work that we're doing around the future is looking at what is coming through the white paper. And one of those areas is around the lifelong learning entitlement that will be coming in 2027. So that'll be another opportunity for us to think about how we can support staff using some different funding to help them with their education, so not reliant on the fixed funding streams that we have now. We also need to think about the entitlement for young people to have work experience placements. And there is a difference between what a 14 to 16-year-old have and a 16 to 18-year-old have at the point in their education. So again, looking to the future of how we can make sure that we're prepared for that. And the widening participation team are very much leading on this work for us. Some of the successes that we've had that I've listed there, again, it's about partnership working. We've got a great relationship with Education Partnership North East, and we look at securing funding for things like boot camps. We're also the new bill that they've got at Ashington. They're going to have a health and care area for that, and we're working with them. The nursing and midwifery education team here are working with them how we can support their staff with CPD, how we can open up pathways for their students to come and have some of their learning here, etc. We've also had an article published in the Health Anchor Learning Network about our work on using apprenticeships. We've been shortlisted for an Innovations Award. We've had the 5% Club that we've achieved. We're the only NHS provider trust that have achieved that recognition. Thinking about our apprenticeships, again, we've got a fabulous reputation. We use all our levy. I don't think there are many trusts, I don't know of any others that actually use all their apprentice levy. One of our neighbouring trusts, not too far away, returns over £1 million of their levy unused every year, which I think is shocking. but obviously they've got their own reasons for that. But again, it's about how we use our levy effectively, not only to attract people to join us as direct entry, but also to support CPD for our workforce. And as you can see, we use 66 different standards across our workforce. And the apprentice levy funding is changing, particularly for level 7s. But again, there was a lot of lobbying to government, and we've now got protection for the supporting our advancing and enhancing practice, which was a big relief for the nursing and an AHP workforce. So we're really clear we've got that. But again, it's not a long-term plan, so we need to work with our HEI partners to think about how we can plan for those opportunities when that funding either runs out or is ceased. I think the other thing around apprenticeships, for me, there was a big opportunity here working across the Alliance of how we could work in partnership and support our near neighbours in having a better joined up approach with that Alliance work.
Thank you. So moving on onto some of the other pillars within the community promise, specifically looking at economy, we're a big purchaser of services, and we have a capital spend, multi-million-pound organisation. Around that, just 9% of our spend is based within our trust footprint area. And the other big thing for me is every month we're putting £34 million in salaries into the pockets of our staff, who then go out into our high streets, into our communities, into our local cafes, shops, and actually spend that money. And again, that benefits our local economy. So it's keeping that, where we can, that pound local. And I think that for us demonstrates our impact as an anchor institution. One other thing which I'd like to draw you on is, I've got a slide later which shows over 300 companies that we're now working with. That number has gone up to 372. So it proves that actually we're doing something right about what we're doing, engaging with small and medium-sized enterprises, and we'll be doing more work in 2026 about encouraging more to sign up to become suppliers with us as an organisation. But one piece of information on there which I think is really important to bring out is the power of our spend, our central core project at Seaton Delaval. We've verified it through NHFM and through Nicola Short, who's come in for a year to work with us, that we've generated £3.2 million in verified added value employment, social value benefits. That's through apprenticeships, direct entry employment, through work experience, going out to schools, engagement, all absolutely verified. And hot off the press, I got an email late last night from Nicole to say that our work in Hexham with IHP has generated £21,000 in charity fundraising. So Bright are going to be doing a piece of work around that. And they're just two small snapshots, Chair, of the impact of our purchase power with our providers doing those extra social value things in our community. If I can, I know that there is a presentation from Claire Winter shortly on net zero, so I don't intend to focus too much on that one, but I would just say 2 points out there. Our net zero heroes around the trust is increasing, that's really good, and the vision of those 3,000 balloons, hot air balloons floating around Northumbria's area, full of carbon, no more. That's how much we're saving, but Claire will talk in more detail about those. And in terms of our inequalities, some big things there about making a difference in our role as anchor institution and touch points in the community. 339 of our staff have now been trained in poverty awareness with our partnership with Children North East. We've got 16 health and wellbeing champions that's going out there supporting people in the trust to help overcome any issues that they have. And shortly to announce at some point, in the next few weeks, is the income maximisation project, which was based on the NHS Lothian model, which we have had out to tender.
We're launching that on Monday.
Yes, that is, I believe you'll be making an announcement on that on Monday. And the NHS Lothian model netted in terms of additional benefits, things to which people are entitled, around £671,000 for staff and for patients. And we're going to be running that here. So just a few little snapshots on there. I know that already those 45 per events has gone up to 56, that's a good thing. Big thing there, is around our retention rate for apprentices. If you are an apprentice, you come in here, you're more likely to come from one of our deprived communities now, because we're doing some really good work around that. But 83% retention rate. And again, that lifelong learning, 259 of our staff would benefit from what we call core skills, basic skills, working with us as an organisation. So again, Chair, what I wanted to say is we did have an annual report last year. There's another one we're working on about keeping our promise, and I hope that what we've been able to demonstrate today is that we are working our way to keeping our promise to our communities, and Ruth and I are happy to take any questions you may have.
Great presentation, thank you. Robert.
Not a question, just an absolute comment. Fantastic work, guys. Absolutely fantastic. This is how an NHS trust should work forward. That social responsibility, really focusing on our community, citizens within our footpath, and really making a difference to people's lives. I'm just blown away. I think it's absolutely great.
Alistair.
With echo Margaret's point, I think loads of really good work, particularly the apprentices and stuff like that. One question was about the mini scrubs. Is that historic or active? Because it kind of gets cited, but I just worry that that was 2 years ago's news rather than this year's news, because the rest of it is all, I know is happening live, and I just wanted to check about the mini scrubs.
So the mini scrubs was funded from the ICB, and so it went out to all primary schools in the North East. So initially we did it in our area, but then from the success it was rolled out across all primary schools. So that hasn't finished, that's a project.
Okay, so we can claim success in it, but we'll probably start winding down claiming success, otherwise people will keep on asking.
And Chair, if I could just add to that, because I had a meeting with Kate a few weeks ago, and she said, what next? Well, the what next is the lanyards that both Ruth and I are wearing, which are the careers ambassadors. We've got over 60 staff who've signed up now to be our sales force, to go out to talk to schools and colleges about real life living, working in the NHS. So we are thinking about those next steps.
Hannah and then Chester.
The question is the same one I asked in the People and Culture Committee yesterday. It'd be really interesting to understand how representative the workforce is of the population that we serve. Yesterday we were talking about disability, but ethnicity, class, and I think about next steps. It'd be really great if you had some sort of visualisation where you could see where we had heat maps of employment, because that would allow you to target areas where actually we could put in interventions to try and attract more people into the workforce.
I think I've seen them, haven't I? Yeah. Do you want to just give a quick response?
Yeah, so we're actually meeting, Wayne included in this meeting, regarding what our strategy is for next year, because I say things change and evolve. So one of the areas that we're again working with the public health team is about looking at those areas, then we can triangulate that with where we put our efforts in. So what I challenged the team with this year was not to keep going back to the same schools all the time. Actually look at the schools where we've got either high incidence of free school meals, for the deprivation indices, etc., and go and target those schools. And the other thing is around the career ambassadors is that, as Wayne said, we've got over 60 now, is of actually, if you can see it, you can be it. So I always say, they don't want a 62-year-old grey-haired woman going talking to a load of school children. They want to see somebody like them. So if we can get young people to go that say, I came as a 16 or an 18-year-old apprentice, and this is what I'm doing now. This is how I've grown from being a healthcare support worker to becoming our ward manager, a registered nurse, or a health professional. And those are the people that will sell the story, not me.
Great. Phil?
Yeah, so many highlights, great, isn't it? But I just wanted to go back on the apprenticeships point as well. And a question for Ruth. You mentioned that others don't obviously spend their levy, and there are often reasons behind that. But can it be transferred, or is it something we could look at on an alliance level of, say, collectively, if we've got the ability to use more of that pot, we can use it, rather than it be organisationally viable?
Yes, you can, and we do have gifted some of our levy in the past to pieces like St Oswald's Hospice, to GP practices to help them, and in fact we've worked with some GP practices and supporting them with their apprentice provision as well through an arrangement. But yes, you can. The ambulance service, because they rely heavy on their levy to train their whole workforce, they actually they receive extra levy from other partners. So yes, it is possible. But again, it's about their infrastructure to support that and their workforce planning strategy to enable that to happen.
Okay, then I think we'll need to move on.
Yeah, fine. Just to echo everyone else's comments, really proud of his work. Thank you to Ruth and Wayne. The one comment I had was around, there's almost a missing slide at the end around what impact that has on us as an organisation and the community. So we're doing all this fantastic work, we're bringing the right people into the organisation. What does that mean then for us? And we've talked a bit about the impact and how we measure that. And that, for me, is things around how these apprenticeships stay on with us, where they get to, how that's affected their lives, families. So it'd be good to just hear or see some of that.
And I'll be picking up that in the annual report because that's a valid point.
Good, that's great. Then you've heard the praise and pride that we feel in it, so take that away. Heard encouragement for working across the Alliance as well, which, as you know, I'm very keen on. And we've finished on thinking more about the impact. So thank you, congratulations, and look forward to seeing the annual report. Cheers, mate. Claire, sorry we're running 10 minutes late. We've had so many really decent conversations. So here we are to get an update on net zero.
Yeah, thanks everyone. It's well timed after Wayne actually with CS. I'm obviously going to concentrate on the environment pillar. I'm going to give a very whistle-stop tour through the last 6 months. Apologies to those that have already heard the presentation both at NHFM board and the EMT. I'm not going to go through everything on each slide. So just to give it this, set it in context from a national point of view. In September this year, NHSE released their 5 years of Greener NHS. So what has happened around the country since the publication of NHS delivering a net zero NHS in September 2020. So overall, very good progress, 14% reduction in our carbon footprint. So this means our scope 1 and scope 2, mainly how every NHS trust heats, lights and powers buildings. So very good from that point of view. Overall 10% reduction in states emissions. I'm going to look at we're looking at 98% reduction in desflurane emissions, and obviously back in 2020 Elaine Winkley was instrumental in being one of the first trusts here to start to ban desflurane, and there's a few trusts still left, but that has been huge and we were a main player in that. Overall 1.4 billion has been secured for PSDS, which is obviously we have been very lucky in 2020, and this year we secured another 20.2 million for the decarb of 3 sites, Wansbeck, NSEC and Hexham. I'll get onto that in a little bit. And essentially the next steps, which we are following because these are, they're leading the way. So we're looking currently at nitrous oxide reductions through our clinical sustainability work, looking at net zero building standards and how we're going to apply them going forward, and very much the net zero supplier roadmap and how we deal with our scope 3 emissions going forward as well. So that sets it in a little bit of context. From a carbon footprinting point of view, you can see by the graph that we have started to see the fruits of our labour when it comes to reducing emissions. There's clearly a time lag for projects that we roll out and the impact of those. We've always had reductions with natural gas because we're rolling out projects across the trust and trying to monitor effectively, and a lot of the natural gas savings we've had are from a much improved monitoring and management campaign, which now we have data, we can obviously manage it much better. Anesthetic gases have reduced hugely, and that has had a massive impact. From a scope 3 perspective, we think we're seeing the reductions in supply chain. Paul highlighted a couple of weeks ago that he isn't quite so sure about that, so we're investigating all of the 18 E-class codes that make up our supply chain, and I'll get on to how we're going to deal with those going forward to develop a much better and accurate supply chain carbon footprint.
Can I just say that was a good feel rather than a...
Yeah, no, it's fine.
Yeah.
So we have been investigating it, but essentially all our effort from the energy team in the last 2 weeks has been to put our submissions in for our NHS decarb funding, which was announced 2 weeks ago. So we've put
that has been all the efforts, but I'll get onto that in buildings. So in our 8 key action areas, we've had some really good progress in the last 6 months. We've obviously had investors in the environment, we've achieved green, which is the highest, and now we're looking at actually how can we progress on from that, where do we go? We were shortlisted for the HSJ Awards. Sadly, we did not win last Thursday night. We lost out to Royal Brompton, which I'm sure they had a great project, but we were still a bit sore about it. There's a lot of work going on from a Great North Healthcare Alliance point of view and how we can work not only with Newcastle but Gateshead and North Cumbria that are not doing quite so much on a sustainability point of view to bring them up to speed, and that is going on in the background. From a people perspective, we've had a number of successful campaigns, particularly Bike Week in the summer, Energy Action Week, which we're going to repeat in conjunction with some charity partners in January. And we're looking to create a bespoke, not necessarily just for Northumbria, but actually it could be for the Alliance e-learning package, whether we actually have a template that we can then sell to other trusts, because a lot of trusts feel the same way as us, that a generic e-learning package just doesn't quite hit home in the same way. From a buildings and estates point of view, we're progressing well with PSDS projects at 3 sites. NHSE opened up submissions for potential investor save projects. They have suggested that there is a budget. We don't know how big the pot is. The closing date was yesterday for investor save projects. We have put in bids worth just over £1 million for energy reduction projects that are mainly to do with BMS, so building management system projects, over the next 3 months, and they have to be rolled out by March 26, which is clearly a ridiculously that's why we've picked projects that are technology based rather than buildings. There is also a different call for submissions for next week, again very short turnaround, for sub-metering of buildings, which we're about to put in today. A cobalt sub-metering bid, which is about £50,000, which will enable us to trial much better sub-metering at buildings with a view to monitoring and managing and driving emissions down even further, saving further cash. From a waste and reuse point of view, we mobilised the new non-healthcare waste contract in July just gone. Huge cost savings on what we had with our previous contractor and a much improved recycling regime. We used to get so many complaints from staff about the lack of plastics recycling. We've now got that in place, and we're trying to make the contract even more efficient. The next stage is putting every bin that we have needs obviously a new poster or a sticker on it, which isn't quick, but that is next on the agenda now. We've sorted out the actual contract. Journeys in clean air, we've done a lot of work here at NSEC, and that's ongoing. We're doing the air quality monitoring at a number of points around NSEC, including the nature trail. We'll be doing that for a year and comparing each month's results, which is we've had really good buy-in from other trusts who are wanting to replicate that around the northeast of North Cumbria, but also northeastern Yorkshire. We've had a great response to the no idling commitment, which was joined by NEAS last year, but we've got several other trusts on board now that are wishing to, in the aid of reducing air pollution, rolling that out. We now have a trust travel plan strategy it's finalised. It is our headline strategy for the trust that is used not only in capital works, but also is a key roadmap going forward for where our travel plans are going for each site. And from a supply chain point of view, we have just had, in the last month or so, we're about to kick off the work. We talked earlier about how we currently have to calculate our Scope 3 carbon footprint. That's from everything that we buy. At the minute, the only thing we can do, which is perfectly acceptable in the greenhouse gas protocol, is that we base our emissions on spend. So as we buy more, our emissions go up. And we do that currently by each E-class code. There's 18 E-class codes, and we calculate it on that. We're going to move to a solution similar to what Newcastle currently do, and other trusts are looking at it, that we're going to ask suppliers to give us their carbon footprint. We do that for Newcastle currently, so our Scope 1 and 2 footprints for the services that we provide, so payroll, salary sacrifice cars, is essentially their scope 3 carbon footprint, which will mean that we're going to move to a much more accurate way of calculating it. We do have to assume that accurate probably means higher, but obviously the only way of managing that going forward is to really be transparent with the data. Currently, if any of our suppliers have really good sustainability programs and are rolling out solar panels, electric vehicles, they are not reflected in their scope 3 carbon footprint. So we want it to be far more accurate going forward. And for obviously a number of years, we're going to have a hybrid carbon footprint, but that will probably allow us to progress much quicker. So Newcastle have got they only have 10% of their suppliers giving them the carbon footprint, but actually it's nearly 60% of spend. So you can see that it works very well. They're 5 years into it. We hope that we can fast track our approach, given we know a lot of the nuances that are associated with it. Greening and adapting, obviously the Sycamore Gap sapling was planted at Hexham yesterday. We had very good, had lots of news coverage yesterday, which was great. And I think we're starting to really see the direct impact of green spaces on population health and how engaged people become, our staff and our patients, as a consequence of that. We currently have a bid application in conjunction with Bright for a nature recovery ranger role, which would essentially roll out our biodiversity action plans. And that we're going to hear, I think it's the week after next, whether we've been successful for that. But I think there's a huge, the engagement we get for patient outcomes is massive. From a sustainable healthcare point of view, we got the Green ED Gold accreditation in the summer. We were the first in the UK, which is brilliant. We've got a new sustainability F3 in place now at the ED. We've just got our work cut out, because obviously George was amazing with some of the Green ED work he was doing, and actually a bit like Investors in the Environment, how do we now push that on to the next stage and become a leader? I've put here that Our Planets is one of the 3 key themes at the NMAP conference this month, but it's been rescheduled until the new year. But I think that shows that we are getting the kind of engagement from a clinical point of view and seeing the outcomes of both cost savings and carbon reductions from a clinical point of view. I've tried to whiz through.
Claire, thank you for the speed. It's almost overwhelming, isn't it? The amount of work that team is delivering. I should start by saying I'm the net zero champion for the board, because I've been involved in this for quite a long time now, and I feel very proud of the work that we're doing at this trust. It's always a bit frustrating that so many of our emissions are down to scope 3 and they're somewhat out of our hands, and it's also frustrating that the more effective we are at measuring it better, the harder the task becomes. So whilst everybody always likes to see a steady, fast progress in reducing emissions, what we're doing is we keep raising the bar all the time, because the bar has always been there. However effective we are, there's an element of running to catch up, but it's great work and I'm really proud of it as well. So put it over to you for any comments, questions, challenges there. Alistair.
Fantastic work. I mean, the reducing and reusing bit's really clear cut. Do we know, you talked about plastic recycling, that the plastic that we recycled is actually recycled and doesn't end up in landfill? How do we assure ourselves that we're not just looking good but not actually making the material difference at the end?
Because we do a lot of third-party audits. That's our, that is the job of the waste team. We haven't always had that. We know now internal audits and external audit is key to ensuring efficiency. So internal, we can identify cost savings and compliance issues, but also those external audits that we do at least once a year with both non-healthcare and healthcare contractors. So yeah, it's very rigorous.
It's good to get these periodic updates. Any more at this point? We'll have a chance to re-engage. When are you coming back to us?
In 6 months, but I think we've got a board dev session in
that's what
February.
I was thinking.
Yes, we're doing buildings decarb.
So we can dig a bit further into some of the big issues. Margaret? No. Good. Then thank you very much.
Thank you.
That's really excellent. Okay, let's move straight on. Stephen, you're here at the point where we're already a few minutes behind, and we're in the final lap. So bear that in mind, please. But I don't feel too guilty about it, because it feels like a fairly assuring report. I mean, there's no serious nasties that I could spot. Are you allowed to tell me otherwise?
No, no real nasties. Yeah, it's accidents again, round about the same as what we had over the previous meeting. 96 in the last 2 months, there was only a reduction of 9. No widows, which is really good. Nothing reported at the HSE over the last 2 months, which is the first time in my time we've had that. So again, that's really good. Abusive staff incidents have risen by 14, by quite a spike in September, 118, and down to 91 in October, but these are all being reviewed. Again, we have our warning and exclusion letter meeting on a monthly basis, and the last 2 months we've spent 15 warning letters and 3 exclusion letters. I think the big thing that's come out over the last couple of months is the NHS guidance for the Terrorism Protection of Premises Act, which is Martin's Law. Yeah. So we now have that guidance. So ourselves in emergency preparedness are working through that. I think the main things we're looking at is we need to nominate responsible persons and designated senior individual. So we're meeting with Marion and Damon in December to review that and who's going to be responsible in each site. We have 5 sites which is on the standard tier, which is between 200 and 799 people. That's Annick Berwick. Sorry, I've got them written down here. But
so that's in the pen.
Yeah, Seatondale, Annick Berwick, Hexham, Blythe, where we have to look at evacuation, lockdown, communication, and also notify the security authority. And then we have 3 enhanced, which is NSEC, Bournemouth and Blythe. So we have to have the evacuation, but also monitor the premises, control movements in and out, which is access control, CCTV, physical safety, security, so how do we stop cars driving or hospitals, etc. So it's quite a good work to do on that. We'll be looking at the gap analysis and then have a report to the board by March 2026. So again, I have the action plans, responsibilities, etc. Fire side of it, internal audits, we've completed 38 audit and departmental audits along with our compliance audits, and by the end of the year our annual report will have all the results in there. But we do have a fire and health and safety action tracker which we monitor on a monthly basis. Fire, we've had 10 incidents reported with no fires, so there will be false alarms. A waste bin was small and was put out outside, I think that was cigarette smoke. Faults were people working within the areas. 8 of the incidents were not reported through DataX, which is ongoing, but we are working with the teams to make sure they do report evidence through DataX. The training, NSEC fire evacuations at 78%. Again, we're working to hit the target of 85% by the end of the year, and the annual fire safety is sitting at 92%. And I've got the dashboards, which is within the pack. I just really want to look at the warning exclusion letters. We've sent 86 out now this year, 80 warning, 6 exclusion. 3 individuals have received 2 letters, and 2 of these are frequent attenders, but none of the individuals who received a warning letter have gone on to receive an exclusion letter, so what we're looking at is really the warning letter procedure is working.
Good.
I had a meeting this morning with the Alliance, including down in Newcastle, South Tynes, so we are working with NIAS, looking at procedures, how we share information of dangerous patients, excluded patients. So we're working on that as well, so that's been a really good piece of work from this morning.
Stephen, that's great news. That's really encouraging. Good, thank you, and thank you for your brevity. Kate.
Thank you. It was just to say as well, in PCC yesterday we received an update on the violence and abuse strategy, which was really, Katie Shotton came and delivered that and talked about what actions are going to be taken over the next couple of months to really delve a bit more into that, which was really good to hear.
I think Martin's Law is going to actually be quite big for us.
Yes.
You know that a local school got closed recently for a similar threat, and I think that this is going to unfortunately be something that we might see more of moving forward. So I think from a board's perspective, particularly given the safety implications both for patients and for our staff, I think that timely updates in terms of how we progress with that, because I think we've got a 2-year period to go.
It's 18 months from now, we have a 2 year from when it came out.
So I think that will become one that the board will need to be decided on.
I have it as a generator on my paper, yeah.
Thank you.
Thank you very much indeed for that. Stephen, thank you very much indeed. Happy to receive. Well, it just shows that at the beginning of the meeting I said we'd have no trouble because of all the items, and here we are. We're going to run over by a good 10 minutes, and I apologise to you for that. We're on to the pod report, which is, I know, has gone through people and culture in detail, so highlights that need to come
Yeah,
back.
sure. I think helpfully we've covered a lot of it during the board meeting today as well. Just to highlight around sickness absence that the increase from September-October was very minimal and the lowest level of absence we've had since October 2020. So although it's not declining, it's stabilising, enabling us to then start the decline, hopefully. I just wanted to say on the staff experience point that we've hit 72%, but I think people know the ambition of mine was to make sure that we're hearing from all of our teams and departments, and actually we've still got 8 areas where we've heard from less than 11 people, and 11 is the threshold in which we need to be able to have a look at those results. So just to put that in context, it's about 240 teams and departments, so we're getting there. We've got a day or so to try and get that down. It's definitely less than it was last year, so good work on that point. And I don't think I wanted to pull out anything else. I think we've probably discussed that, and I think the dashboard shows some good performance across all the learning and OD compliance. Still work to do on a number of areas. There were the main points.
Thank you. Katie, anything you want to highlight?
No, nothing further.
Comments, questions from the board? Thank you very much indeed. That's really a positive step. And there's feedback from the audit of sexual misconduct in the workplace, which is really positive,
Yeah.
but 3 of them are still amber.
Yes, yeah, absolutely. So it was just to make the board aware that there's 2 different action plans, and one of the action plans was because when we were written to over a year ago, we started to develop our own action plan prior to the assessment coming out, and then the other one is the assessment. I have asked the team to just bring them both together because I think that makes a lot more sense. So our main areas is around how we escalate some of the complex, the language is complex, situations, I think they're all complex, so we just need to look at that and how we do escalate those and what data we can provide. But I think it was helpful in PCC yesterday because we've started to report on our sexual misconduct cases that end up in a formal process. And over the past 2 years we have had 11 within a formal process. But I agree with you, Chair. I think there's lots of progress being made and it's very well cited across the committee.
And the people in culture are all over it. Okay. Are we happy to leave it to people in culture? Good, but emphasise the importance of it and board commitment to this area as well. Yeah. Good, thank you very much indeed. We're into the governance bits where I know sometimes, Ross, we tend to take them almost for granted, and here we are, we're allowed to take it for granted. Stakeholder engagement.
Yeah, I think that's fine, Chair. This is really just a formal kind of reassurance around stakeholder engagement. I'm happy to say we're fully compliant on this, and you can see the paper every month just really triangulates a lot of the detailed work Joe's doing with direct patients and families, and then the wider work we do with sort of communities and the public. All feels like it's in a really good place, but we are sort of horizon scanning a little bit now as to what happens next when we start thinking about things like IHOs and how we speak with our communities and connect with those in perhaps different ways. And I think some of that discussion we started at governance last night, and we just need to make sure, I think, that we're ready for any change that happens and how we maybe turbocharge some of that into the new world.
And maybe just capture the discussion for those of us, almost all of us that were at governance last night. We are going to be looking, and Ross will be leading a process of considering how we can identify what it would take for us to become the exemplar in patient and public engagement in the future, and what implications that might have for the future role of governance. Any questions, or happy to receive? Thank you. Chris, the back.
Thank you. I think I probably just want to say, Chair, around the kind of conversations that have been going on in the subcommittees. I think we're getting much better, richer conversations with much more feedback and changes to the BAF. We've got a couple of bits that just with in terms of timing. I know PCC had a good conversation yesterday around what needs to be included in terms of those actions, mitigations, etc. So that's the kind of main thing I kind of want to say this morning. I think we're kind of moving the conversations along quite well.
Are we happy that it's going in the right direction? Are there any points people want to raise at this point? Yeah.
Just a question, because this is aligned to what will now be known as the old big signals.
Yeah.
And so I guess selfishly, I used to have a big signal I could hang all of mine on, and that won't be the case. It would be, it was useful to have her continue to make progress digitally as a big signal for this, and we won't have that anymore. So there's just some sort of re-slicing of this to match the new version of the big signal.
Absolutely, yeah. I think it comes back to the point the issue made when we talk about the refresh big signals in terms of, yes, we'll have those 4, but underneath those, I think we'll still have those subsets. So, the services for the future will have a subset of digital, a subset of states, for example, etc. So you'll still be able to see those clumped together in there.
Okay. Good. Happy to receive. Right, we're into the exception reports, and these have been through for assurance the committees. So I'm really not asking for too much on this stuff that is necessary. So first of all, the nursing and midwifery assurance.
Nothing really to report.
Okay,
To the chair to speak of the trade.
Thank you. Did anything come from SQI? Margaret, that we need to highlight? No? Okay. Happy to receive? Okay. And with AHP assurance?
Yeah, just the same. With that, just teams are working very hard just to compete with all the challenges through this last month.
Yeah. Any questions, comments? No. And the maternity pyramid.
So this has obviously been through the operational board, and we're quite happy that work is ongoing, not complacent, but we will keep going through all the various iterations of the report.
And we've got further wider discussion coming up in due course, that's soon. Good. So any points to raise in regard to that? No? Thank you. And the corporate report, Chris?
So I don't think there's anything else to add on.
No.
Nothing else to add further to that from the discussion.
That's gone through fit. Phil, anything to highlight, or we happy just to receive? Okay. And similarly then with the finance report?
Just to confirm, this was discussed in detail that we remain on target to take financial targets for this financial year.
Phil, anything you want to highlight?
No, you don't.
All good? Colleagues, thank you. Then we're into any other business, and there's just the one, which is our opportunity to note this is Andrew Bestford's final board meeting. You've been with us 6 years, and in fact it'll be 6 years and a little bit by the time, because we extended you up to Christmas to give to extend the opportunities of handover to Sarah. And I think we all know how our digital work has progressed in the 6 years since Andrew started. But it's not just digital, it's too easy just to pigeonhole him as that. He's been a great colleague for ours, hasn't he? Great colleague and friend for the Trust, and we're going to miss you very much. Thank you very much. Thank you. Any agenda for the next meeting? Has it approved? I ran over the time, I'm afraid, but only by 7 minutes. I hope you can forgive me. We'll start the corporate one 5 minutes later, so that we'll split the payment. Yeah. Okay. So the corporate trustee meeting will now start at 5:01.